sure. Live nodi. Live nodi. ಆಗುತ್ತದೆ ಅದು ಏಕೆ ಇಲ್ಲಿ ಯು ಎಸ್ ಪಿ ಆಗಿಲ್ವಾ ಇಲ್ಲ ಇದರಿಂದ ಆಗುತ್ತೆ ಇದನ್ನ ವೀಡಿಯೋ ಕೊಟ್ಟು
ಅಲ್ಲಲ್ಲ ಮಧ್ಯಾಹ್ನಕ್ಕೆ ಇವಾಗ ಹೇಳವಲ್ಲ ನಾವು ಮಧ್ಯಾಹ್ನ ಅಲ್ಲಿರಲ್ಲ
Okay.
So,
starting off the live surgery session, we have two of our chief residents here, Dr. Akshay and Dr. Priyank, who will give us an insight into the case capsule itself, which includes the discussion about the case as well as the radiological imaging. Dr. Akshay?
Good morning, everyone. I'll be just giving a brief overview about the case which we are dealing with today. A 41 years old gentleman who is farmer by occupation, he presented to us with the chief complaints of he had headache from last 4 years and generalized tonic-clonic seizures, 2 episodes from last 15 days back. He is not having any known comorbidities. On examination, patient was conscious, oriented to time, place and person. His cranial nerve examination as well motor examination were normal. On neuropsychological evaluation, his MMSE score was around 27 by 30 and Montreal cognitive assessment was 26 by 30. He had impairment in visual memory, immediate recall and delayed recall, which was suggestive of right temporal lobe involvement. Apart from that, the rest of the examination was normal. Now my colleague will be discussing about radiology of this same patient.
Good morning, everyone. So as Dr. Akshay presented, it was quite difficult to localize the case based on clinical only. And when we went ahead with the radiological examination, find out that there was a iso to hypointense mass in right side temporal lobe, inferior temporal gyrus mainly predominantly involving, and it was also showing some cystic areas. As we can see in this T2 images, one minute. Sorry, it's not. No, it's not stopping. Should stop here, right? It's not stopping. Sorry, it's not pausing the way it should, but. So anyways, in T2 images and also the FLAIR images, we could see some heterogeneous hyperintensities with some cystic areas in the right inferior temporal lobe. also layer images confirms the same thing. There were some cystic areas along with some minimal surrounding edema. And post-GADO, there was some heterogeneous enhancement, very less area, like we can see in the periphery it was enhancing. So we can see in the right infrared tumor there is just mild enhancement, heterogeneously enhancing, special. So that's all about the radiology. Next we'll take live from the surgical room. Thank you.
We'll have a detailed discussion about the MRI with Dr. Shabri and Dr. Charlie Theo himself in some time as they set up. If there are any questions regarding the case from anyone in the audience, please do let us know. Yeah. Live हो गया OT के?
ಕೊಡ್ಲಾ
OT you take the first
ಕಿಟಿ ಹಲೋ ಬಂತಾ ಬರ್ತಾ ಇದೆಯಾ ನೀನು ಆ ಕಡೆಯಿಂದ ಚೆಕ್ ಮಾಡು ಸ್ವಲ್ಪ ಲೈವ್ ಕೊಟ್ಟಿದ್ದೀನಿ ಮಾತಾಡ್ತಾನೆ ಬಗ್ಗೆ ಓಕೆ ಸರಿ ಬಿಡು ಅದನ್ನು ಅಲ್ಲಿ ಇಲ್ಲಿ ಬರಬೇಕು ಅದು ಓಕೆ ಆಗಲಿಲ್ಲ ಇದ್ರದ್ದು ಸ್ಟೀಮ್ ಯಾಕೆ ತೊಗೊಳ್ಳಿಲ್ಲ
Because we always wish to have the FMRI and DTI on a single navigation based platform, but then that has remained wishful thinking so far until the Connectome came into picture, where we can easily see the functional networks and see the relation of this tumor along with networks. I think now we can have Dr. Teo to come in and then take it forward from here. So just hang on, in another 5 minutes probably we can take off from here. Thank you.
Dr. Shabri, can you hear me? Vinay here from radiology. Hi. Yeah, what was impressive is the tool of tumor segmentation, so that in this situation where the border of the tumor with the normal brain is not clearly evident,
Dr. Shabri,
and
can you
actually
hear me?
tracking that margin is rather
Vinay
time
here
consuming
from
and
radiology.
highly
Hi.
prone
Yeah,
to
what
an
was,
error. So I think the
impressive is
AI
the tool of
segmentation
tumor
algorithm here is
segmentation,
really
so that
what is
in
striking.
this situation
And
where the
border of the tumor with the normal brain is not clearly evident,
Dr.
and
Shabri, can you
actually
hear me?
tracking that margin is rather
Vinay
time
here
consuming
from
and
radiology.
highly
Hi.
prone
Yeah,
to
what
an
was,
error. So I think the
impressive is
AI
the tool
segmentation
of
algorithm
tumor
here
segmentation,
is really
sure,
what
thank you.
is striking.
In this situation
And
where the
border of the tumor with the normal brain is not clearly evident,
Dr. Shabri,
and
can you
actually
hear me?
tracking that margin is rather
Vinay
time
here
consuming
from
and
radiology.
highly prone
Yeah,
to
what
an
was,
error. So I think the
impressive is
AI
the tool of
segmentation algorithm here is
segmentation,
really
sure,
what
thank you.
is striking. And border of the tumor with the normal brain is not clearly evident, and actually tracking that margin is rather time consuming and highly prone to an error. So in the AI segmentation algorithm here is
Sure, thank you.
Check. Hello. Hello. Check.
Yeah, we can just about hear you, Dr. Tia.
Well, welcome everyone to the operating room. It's good to be back on the saddle. We've got a patient here who has a complex glioma of the right temporal lobe, and it's complex because it seems to be almost two separate tumours. I'm sure it's connected, and I'm sure it's the one tumour, but it's certainly multi-lobulated. It almost looks like a dumbbell, with one portion of the tumour in the inferior aspect of the temporal lobe, touching the skull base in fact, and the other portion of the tumour above and behind it. And what I'm going to do now is probably just go through the MRI scan with you without any sort of guidance and without any mapping, and just go through a standard MRI scan and show you what I'm looking at, and then tell you what I'm thinking about as I plan my operation. So maybe if you can turn that camera around, or will I turn this around? I'll turn this around.
It's on the screen. There's a
Oh, it's on
live
the
relay of the
screen.
screen. Yeah.
Oh, fantastic. Okay. So does anyone know how to use this? Stealth? You know how to use it? So get rid of all the QuickTime stuff. Yep. And go to single screen, and I just want axial T2 if you've got it. If you don't, just axial T1 is fine.
It's on the screen. There's a live relay of the screen. Yeah.
Oh, fantastic. Okay. And get rid
So
of all
can
the,
anyone, does anyone know how to use
rendering.
Stealth? You know how to use it? So get rid of all the... I'm sorry, I don't know how to use Stealth. I've always used BrainLab. I've never used Stealth before, but we've got the expert here next to us. Okay, so
It's on the screen.
I'm going to assume that you guys haven't seen this, and we're going to start from the start and go through the scan. This is a T1 axial scan with contrast, no, without contrast. And I'm going to start right down to the skull base and show you what we're looking at. Brainstem, cerebellum, and we're starting to see the temporal lobes, temporal lobe here and temporal lobe here on the right. And remember, the image is switched around, so it's normally the right side, this side and left side, but this is now left and this is right. And now we're coming up on the axial slices, and already we start to see something abnormal in the temporal lobe because you don't see the normal sulcal pattern. This abnormality continues, and it seems to be quite well demarcated down here. This is a normal sulcus at the temporal pole, and this is some sort of low-intensity tumour. Same thing here. So I guess what I'm saying is that this is the inferior component of this dumbbell-type tumour. So we have temporal pole preserved, well demarcated, low-intensity, reduced intensity tumour, and again, here it is here here, coming to the surface, right here. I don't know if that's, I don't think that's enhancement. I think that's just a bit of, oh no, there's no contrast anyway. That's just a bit of normal brain there. All the way back to the petrous bone. This is all tumour here. Still tumour. It's all the same tumour, all coming to the surface, all the same tumour. Again, now it's starting to get smaller. This now looks like normal cortex. This is all tumour here, and then it kind of disappears. And it's certainly obliterated the temporal horn, and it looks like there's normal cortex on the outside of it. Okay, it's still a bit of tumour there, still a bit there, but it's going to disappear soon, and it's probably disappeared now. Okay, now as it disappears, you see some hypo-intensity posterior to it and superior to it. And if we watch that, that turns into another tumour. So we're going to follow that up, and here it is here. Now it could be edema in this gyrus, but it's likely to be tumour, I think. Oops, are we going up or down? We're going, yep, here we go. And now what happens here is, again, something's occurring here, coming to the surface. This is probably tumour here. This is much more likely to be tumour. And look, this is something that you've got to keep an eye on. There's going to be a sulcus as a posterior limit of this tumour. Sulcus, tumour. Sulcus, tumour. Now what happens here is, again, sulcus, tumour, and a bit of normal gyrus there. Maybe a bit of normal gyrus there. This is clearly tumour. This is just as big as the temporal one. Yeah, tumour coming to the surface. Tumour coming to the surface, and not just as big, I think it's bigger. I think this component is bigger, and there it is there, disappearing in front of that gyrus. Okay, now I'm not quite sure if that's temporal lobe or parietal lobe, so what I'm going to do is look at the coronal. So we're going to get the coronal and see if it comes above the Sylvian fissure, but I don't think it does. I think it's contained within the temporal lobe. So now we're just going to go as anterior as we can. So what we have here is the back of the orbit, and we have the anterior cranial fossa, the cribriform plate, and we're going backwards now. We start to see the left temporal pole. Patient's twisted a little bit, so we can't see the right temporal pole yet. And now we start seeing the right temporal pole, and again, you can see clearly it looks abnormal. That grey-white interface isn't present on the right side, so we're into tumour already. And actually, no, it wasn't tumour, that was just squashed brain. So here's the tumour now, like we said, skull base coming up here. This is all well demarcated inferior lobule of the tumour, going up into this area here. This is called the temporal stem. This is the insula, and you can see that it's starting to head up into the insula. So, you know, we want to make sure that we get to the edge of the temporal stem when we take this bit out, and not go into the insula. So, okay, so here it is, well demarcated. Well, Dean, okay, now we're going backwards. We're going backwards now. Still tumour. Look, a little bit of a cystic component to it there. And of course, this is all temporal lobe. There's the Sylvian fissure. So I'm thinking the other component of it is going to be, again, in the temporal lobe below the Sylvian fissure. And it is. It is. Here it is now. It's starting to come up. And to me, it kind of looks, it almost looks like it's separate. That is kind of weird. Look, there's normal brain in between. So this is that temporal tumour going, normal tumour in between, normal tissue in between. I cannot see a communication between the two of them. I think it's a separate tumour. Maybe here, yeah, maybe here. Oh, look, yeah. Okay, so posteriorly, the two kind of fuse together. And now this one's disappearing and this one's appearing. And then this disappears as well. Okay, so I think you guys can appreciate the importance of mapping here, because I'd like to know if this tissue here was functional or had any parcels in it, because if it didn't, I would sacrifice it. You know, I'd just take all of this tumour, and take all this in between with impunity if there's no parcels in there. So I think if there's going to be any parcels in there at all, they're probably going to be parcels of, given it's the right side, I'm sure speech is not there, but there's a network called the Central Executive Network. Now, you don't know what that is yet because we haven't given you a talk, but one of the new networks that has just been identified by all this research into the human connectome has identified a very high order network that's very instrumental in working memory and task-driven function. And sometimes there are parcels within the temporal lobe. So I'd like to look at CN. Have we got CN? So what we're going to do now is we're going to overlay the Central Executive Network onto this MRI scan and see if in fact there are parcels or cortical regions in that area that may be part of Central Executive Network. Memory and task-driven function. And sometimes there are parcels within the temporal lobe. So I'd like to look at CN. So what we're going to do now is we're going to overlay the Central Executive. Okay, here we go. Onto this MRI scan. Now I'm sorry. No, just cortical region. So I'm sure you don't even know what parcels are. So if you remember your anatomy, there was a guy called Broadband in 1908 who described the cortical surface of the brain and 47 different areas. They were called Broadband areas. Well, right up until 2016, we accepted Broadband's map as the standard map of the brain, and anything that was not given a number was considered non-eloquent brain. And that means that we could sacrifice it without causing any problems. That's what we thought. Now, of course, you're going to learn today that we were completely wrong and operating in the dark ages. Now that we've been illuminated and informed of what is really happening, it turns out that those non-numbered, non-eloquent areas actually have numbers, have eloquence, and are very important in the functions that make us different to animals. We call them the higher order networks or the higher cognitive functions. And I'm talking about things like using your imagination and maintaining hope and enjoying pleasure and feeling the pain of oneself and the pain of others. These are sort of very, very higher cognitive functions that can have an incredibly negative impact on your life if they're destroyed. And we would destroy them on a daily basis previous to 2016, not knowing that we were actually destroying them. One of those networks is the Central Executive Network. It's very, very instrumental in maintaining higher order task-based functions. Like, if you don't have a Central Executive Network, you're not paralysed. You can get into a car, but you can't drive a car. It's all too complex. And so I want to make sure I'm not going to damage any of the CEN, Central Executive Network parcels. What we have here are these little marks, and these are all parcels or part of that network. And at this stage, I can't see any of them down here. So that's good news. But we're just going to go right from the start again. At the front, we're going to go back. And, here it is here. Now look at this. Now, remember, again, you don't know this, but I'm going to tell you now that the software that Chabri has used is called QuickTome, and there's one thing about it that everyone has to know, and that is it's incredibly accurate. So I don't want you to think that this or this is an artifact. It's not. These are parcels, cortical parcels that are part of the central executive network. Oh, look at that. Look at that. So this has been extremely helpful already, because what it's done is shown us that that tissue between tumour and tumour probably shouldn't be sacrificed. It's a slither of tissue, and it's anterior. Now, posterior, sure. If you go posterior, you're going to find it behind this one here. Actually, no, it's pretty eloquent, that brain. So anyway, we know that where there's this definite sort of demarcation between tumour and tumour, there's potentially functioning brain. Now, this is not a functional MRI scan, so we don't know how important those parcels are. We just know that they're there. And we know that they're part of a network that could have pretty devastating consequences if we hurt them. So this is going to completely modify my operation. What I'm going to do is I'm going to just concentrate on this tumour here, take that out, that's the easy one. And then I'm going to go posteriorly, find this tumour, and again, take this one out, but try and preserve that tissue that runs between the two. Now that's a big ask. And so it's going to take a lot of skill and experience to try and maintain the integrity of that bit of normal brain. Absolutely. 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 So what Shabiri is saying is Shabri. Okay, so my Indian's not so good, and my Indian pronunciation is even worse. Okay, so Shabri has made a very, very valid point. Here's the valid point. Previous maps of the brain identified parcels and cortical representations, but they weren't patient-specific. In other words, they were simply an atlas overlaid over the patient's scan, and they would tell you where those important areas were likely to be, but not where they were. This software is different, and I think this is a perfect demonstration of how accurate this system is, because this system, through Genius, machine learning and AI, has now managed to find those parcels in the patient. So these are patient-specific parcels. These aren't where the CEN ought to be. This is where the CEN is. And I think the fact that these parcels correlate so accurately and perfectly with what we predetermined was normal brain validates how accurate the system is. So again, it makes our life a bit more difficult, because if they weren't there, we could just pretend that was non-functional. And it still may be non-functional, just remember that. It still may be, but I'm not prepared to glibly take that risk. Now, we might destroy it anyway, but we're going to try and be careful and maintain those parcels. Okay, now, there's another thing that we should watch out, and that is called IFOF. And IFOF stands for the Inferior Fronto-Occipital Fasciculus. It's a major highway between the front of the brain and the back of the brain, and it is instrumental in many different functions. For example, on the dominant side, on the left side, if you hurt IFOF, you hurt someone's speech. On the non-dominant side, because it's not associated with speech, it's still associated with language. And that means that you can still get language problems when you destroy IFOF. Now remember, language is more than just speech. It's comprehension, it's accessory language, it's verbal language, visual language. All these things are part of language, not necessarily speech. And destroying IFOF on the non-dominant side can still have pretty dramatic effects on someone's speech. Oh, sorry, on someone's language. So what we're going to do is we're going to now look at IFOF, and we're going to put IFOF on the patient's MRI scan and hope that we're going to miss it. Well, again, the anatomists in the room will tell you that IFOF is at the inferior margin of the island of Real. This is the island of Real, R-I-E-L. Underneath it is the insula, and right at this point right here is usually where IFOF runs. So the fact that we can see these where we think they should be, again, validates this program that it's telling us where IFOF really is. And I don't think we have to worry about IFOF. It's about 2 centimetres away from the dome of this lesion. And that's exactly where you'd expect to see IFOF. And look at that, we're safe. Okay. And then as we get to the second lesion, there's those parcels. Again, IFOF is pretty close. It's pretty close, but not in the tumour. No. Okay, the next one we want to look at is the optic fibres, and the best way to look at that is on the axial. So if you wouldn't mind going back to the axial, get rid of all those other things and just look at optic. Now again, for the anatomists and the medical students in the room, I'm sure you've heard about Meyer's loop. Meyer's loop is the anterior and lateral extension or loop of optic radiation that covers the roof and lateral walls of the temporal horn of the lateral ventricle. The worst thing about Meyer's loop is that you can't assume that the optic radiation fibres extend posteriorly from the optic tract to the calcarine fissure. It doesn't. It's not as simple as that. It loops forward and anteriorly, and hence they can be damaged when you do a temporal lobe dissection or a temporal lobe tumour. So we're going to now look at, so these are all I'm not quite sure whether that's not, oh no, this is the one that you did, isn't it? Yeah. Okay, so unfortunately there's a bit of a, oh, both are in one, okay. You can't just give me optic radiation, can you? Look, I'm so sorry, but this is not correct. This is adding more than just visual fibres and optic and visual system. It's looking at central executive network as well. We looked at the optic radiation only last night, and I can reassure you that the optic radiation is, yeah, and it's actually quite medial to the tumour, and really not really at risk. Yeah, but if we stick within tumour, we should avoid it. Yeah. Okay, so that's been a very worthwhile exercise. What it means now is that I'm going to position the patient so the right side is up and almost perfectly lateral. I'm going to also extend the head a little bit so the temporal lobe falls out of the middle cranial fossa to again help me get the skull base portion of the antero-inferior portion of this tumour. And if I had the patient perfectly lateral, it'll keep me orientated as well. So that's what we're going to do.
Dr. Shabri, could we switch to the operating room field to see the positioning? The video?
Nishit, can you hear me now?
Yeah, so we have the stealth screen displayed here.
We'll get the camera to the head.
Yeah, so that we can see the patient positioning, please.
Yeah.
We have pin. So are we going to take this off? Does this come on? Okay. But first of all, let's position the patient first.
Nishit, can you
we get
see
a
it now?
towel or something underneath? No. Give us sandbag first.
No, we're still on the stealth screen.
No. Under the shoulder. And lengthwise. What do you? Okay, so you should bring that camera this way, like that. Need this. Bring that over here. Well, can you hear me?
Nishit?
And can you see the patient?
Yes, yes, we can.
Okay, so I am very, very particular about the way I position my patients. Because in many circumstances I've managed to take out tumours that other people can't take out simply because I've positioned the patient correctly.
Right.
It's extremely important to make sure that the patient is positioned so that it's going to be a comfortable position for the surgeon for the entire case, firstly. Secondly, that's going to be comfortable for the patient and nothing is being compressed, like, you know, jugular veins and ulnar nerves. And thirdly, you've got to make sure that you position the patient so that the brain does not fall into the cavity when you take the tumour out. Because if the brain's going to fall into the cavity, you're going to need self-retaining retractors or brain ribbons to hold the brain out. So notice that I've pulled the patient over to the right side already. So that's the first thing I do. If I'm operating on the right side of the patient, I pull the patient over to the right side. The reason being is because the last thing you want to do is be leaning over the patient like this for the operation. That's going to hurt your back. And so you want the patient to be as close to you as possible. If I'm operating the right side, they've got to be on the right side of the bed so I don't have to lean over like that. First thing. Second thing is I'm a right-handed surgeon. So if I'm a right-handed surgeon, I want the scrub nurse to pass me the instruments in my right hand without crossing the patient. Now what that means is that if I'm on this side, for example, and the nurse is on that side, every time it passes me an instrument, it goes across an open brain. That's unnecessary danger. All it takes is just thinking about the case before you do it, and you won't have to subject the brain or the patient to that sort of danger. Okay, so I'm going to be a right-handed surgeon operating on the right side of the patient or the top of the patient. I want the nurse to pass the instrument to my right hand, so the nurse is going to be standing on this side of the bed with all the instruments on this side of the bed, not on this side of the bed where it passes across the brain. Do you understand?
Right.
Okay, so all these little things are important when you are approaching difficult tumours or tumours that are going to take you a long time, hours and hours out in the operating room. You've got to get it right to start off with. Okay, so if you wouldn't mind holding the head, and then we'll put the pins on. Okay, so even after 37 years and 11,000 brain tumours, it is still incredibly easy to get disorientated once all the drapes are on a patient. So you want to try and improve all the cues in the room to make sure that you don't get disorientated. Some of those cues are, for example, positioning the table. If the table is angled, then of course you're going to be totally disorientated. If the table is perfectly perpendicular, parallel, and the head is perfectly parallel and perpendicular, it helps you orientate during the operation when everything's covered. You understand these things? All these things are very important when you're doing difficult cases. Okay, so the bed is perfect. It looks maybe a little bit crooked, is it? Maybe a little bit crooked. Can we just release the bed? Okay, just perfect. Good. Now lock it. I know that seems a little bit pedantic, but again, everything helps.
Right, sir.
Okay, now the way he's holding his head is wrong. We want the patient perfectly lateral. So if you can just go perfectly lateral, all the way, perfectly lateral. And again, this will help you orientate yourself during the operation as well, perfectly lateral. And if we can't get perfectly lateral, we need more bolster under the shoulder. Have we got a bigger sandbag? Because the last thing you want to do is stretch the neck or obstruct anything. Yeah, that'll do. Just put that under there as well. Excuse me, we're just going to bolster a little bit more. Oh, sorry, the bed should have been locked. Sorry. Is it locked? Okay. Okay, so we're just going to bolster the patient a little bit more. We're going to make sure he's over to the right side. Yeah, good. Okay. That's beautiful. Now, perfectly lateral. Just a little bit more, a little bit more. Beautiful. Okay, so again, it's going to really help with our orientation this time. Okay, let's put the pins on. Okay. And when you put pins on, try and be cosmetically aware. So we'll just try and keep that one behind the hairline.
Any comments about comparing the Mayfield and Sugita head fixations?
Oh,
yeah. Any particular advantages or disadvantages?
Yeah, I see. Yeah, this it's a little bit quicker to put on.
Yeah. And it's easy to apply.
Easy to apply.
Mayfield.
Yeah, you should get yourself a Mayfield. It just makes your life a lot easier.
Yeah.
I mean, I know that you guys are pretty good at this.
I guess the Mayfield, I've used Mayfield earlier. Maybe the space occupied by the clamp is a bit lesser, I feel. You know, the half the circumference is taken care by the Sugita frame. So.
Yeah. No, I like Mayfield. Can you check, are they tight enough? That's tight enough? Okay, now it's the surgeon's responsibility now to position the patient the way he wants them. So I'm going to ask this chap to let go of the head, and I'm just going to position the patient myself. So let go, just let go, I've got it. Okay, you let go as well. And now I'm going to position the patient so it's nice and comfortable. Now remember what I said, I want it extended so the temporal lobe falls out of the middle cranial fossa, and I want it perfectly lateral. So there we go, fix me there please. No, don't move me. Don't move me. Don't move me. You move you. Yeah. No, let go. Let go. Undo it. See what he did? He pushed me up when he was trying to connect that. Don't let him do that. So I want the position like that, and he has to move, not me. Can you do it or not? You can't do it? Okay. Okay, that's the best you can do? Okay, let's just accept that. That's the best you can do. Don't, take hands away. Can you get it in or not? Okay, now put it down as far as you can for me so I can really extend it. Yeah, I'm happy as long as you're happy. Are you happy? I'm happy. Yeah, go and fix it now. See, everyone's trying to ruin my operation. See, they're trying to push me up. Beautiful, beautiful, beautiful. Okay, good. Now look at that. That's hyperextension. And the reason I've done that is because we are going to do a little bit of reverse Trendelenburg for ICP reasons, and when we do reverse Trendelenburg, that won't be as extended. So can we put a little bit of head up? Other way. No, I don't want the table broken. I want reverse Trendelenburg, not head up. Beautiful. Keep going, keep going. Yep. No head up, just reverse Trendelenburg. Okay, I know I sound a little bit pedantic, but if you really want to get maximum ICP conditions, you want the patient to have the least amount of venous congestion as possible. Right. When you sit the patient up, you actually get some compression of the abdominal cavity and the abdominal contents, and that will actually increase the ICP. If you go reverse Trendelenburg, then you get venous pooling, reduced venous pressure. So that's important, okay? It's not head up, it's reverse Trendelenburg. So again, all these little things count. I know it sounds like I'm being very particular here, but I am particular. And the reason I can take out tumours that other people can't take out is because I don't compromise with those little things. Positioning the patient, head turn, hyperextension, all these little things all matter in the end. Okay, that's beautiful, thank you. Okay, rightio, and now we'll just use the frameless guidance to show us where the tumour is. And if you don't mind, I'll get you to do that. So those students in the room that don't know what we're doing, we're going to use a thing called frameless guidance stereotactic guidance. And what it is a means of using like a GPS system for the brain. Oh, no, wrong. Okay, here we go. Again, look what he's doing. This is wrong. Okay, now, the last thing you want is anything to get in your way when you're operating. Now, for example, the microscope's going to come down here, so the last thing you want is this thing to get in the way of the microscope. And not only that, there's going to be times that I might want to come over here and look in this direction. So the frameless thing, the fiducial, has to always be below the level of the head. Do you understand? Because it wouldn't be terrible if it actually got in my way. And it will get in your way if it's above the level of the head. So this needs to be rotated down a bit. No, just rotate it. Let's loosen it and rotate it. Like that, like that. Yep, good. Okay, and that level there looks pretty good. See that? Thank you. Okay, thank you. And again, you want to make sure that this thing doesn't get in the way of your scrub nurse. Anytime somebody hits it, they run the risk of changing the accuracy of it. So when you position this, position it being cognizant of the fact that you don't want someone to knock it, the surgeon or the scrub nurse. No, nothing. No.
So I guess that would take us to a discussion on retraction versus non-retraction surgeries. So what would your opinion? So how is your practice changing now in the era of non-retraction surgeries?
Well, the last time I used a fixed retractor was 35 years ago.
Okay, wonderful.
So if you position the patient correctly, if you do all the things I'm going to show you to do, then you will never need fixed retraction. Now, I'm not a vascular surgeon, and I agree that some aneurysms require a little bit of retraction, but tumour surgery, never. No, never. Oh, sorry, I'll get out of the way. So for the medical students in the room there, we're now referencing the pointer. And the way we do that is that reference point now is fixed to the patient's head. As the patient's head moves, that thing will move as well. So now we know where the head is in comparison to the pointer, in comparison to the fiducials, and we can now register the patient to the preoperative scans. It's called registration, and it requires fixed points that are recognised by the scan. And so we're going to fix the patient's points as well by rendering the face. And you'll see on the screen that the face has been rendered by the MRI. So we're rendering the face, which will then mirror the rendering of the scan, and then we'll know exactly where the patient is compared to the preoperative pictures. This is very old-fashioned. What we use now is a laser pointer. The laser pointer really is much nicer. You don't scratch the head. Look at this, they're scratching the head. We need a laser pointer.
Brainlab has an amazing.
Oh yeah, Brainlab is very user
It's
friendly.
beautiful.
Yeah,
Yeah.
very user friendly. So if you don't mind, take off all the rendering. Don't put any tracks on it or anything like that. We just
Proceed to navigation.
just go straight to navigation. And now what I'm going to do is I'm going to now get a pen and I'm going to draw on the surface where these tumours come to the surface. I'm going to have to put my glasses on because I can't. You can't bring that closer, can you? Because, but no. Oh, can you? No, it doesn't matter. I can see. I can see. Actually, I can't see that well. Yeah, can you make the images bigger? Yeah. Oh, there we go. No, that's good. That's good. Okay. Rightio. So what I'm going to do now is give myself a bit of offset. Yeah, switch off the light and give me 1 centimetre of offset. Can you do that? Offset it. Offset it. Yeah. 1 centimetre of offset.
Projection, please.
Okay, stop. Oh, too much. Is that 1 centimetre? No, get out. Is it really? That's 1 centimetre. Okay, rightio. So now I'm going to mark the surface markings of this tumour. So you will see that it never gets any more posterior than that's tumour, isn't it? Yeah. And then posterior than there. So it never goes any more posterior than there. So put a point, just a point. Okay, it never goes any more superior than... It never goes any more superior than that. Put a point there. And it never goes any more... This is the top one I'm talking about. And it never goes any more anterior than... there. Okay, so where are the 3 points? Let me have a look. So it's telling us that the more superior posterior tumour is going to come to the surface around about here. Okay, let's go to the inferior. Oh, my glasses just broke. Hang on. Let's now go to the... yeah, I better not be wearing them when I'm operating. I'll fall into them. Okay, now let's go to the inferior tumour. And we know it's all the way down the skull base. And it never goes any more anterior than that. And it never goes any more superior than... Never any more superior than that. And of course it merges imperceptibly with the other one. So the inferior tumour is like this, and it never goes any more superior than that. And they sort of kind of merge there, don't they? They merge at the anterior part or posterior part. Let me just... Okay, now let's see if we can identify where that sensitive tumour is, normal tissue is between the two. And I think it's going to be, yeah, right there. Okay, yeah, so we know that, okay, good. Right, yeah. So, okay, now that we've identified where the surface marking of the tumour is, I'm going to figure out an incision that will allow us to expose all of that. Okay, so here's a zygoma. We don't want to go below that too much. I think a simple incision like this is probably going to do the trick. Let me see now. I don't want to go too far below the zygoma. I want to... if I go like that, for example. Yeah, if I go like that, I can come down here. Okay, so that incision like that. Okay, so what I'm going to do now is just pretend I'm putting a self-retaining retractor in. I'll get it there. Yeah, that's going to be fine. Okay, so we've got a straight incision. Can everyone see it?
Nishit, this is
Yep.
visible there?
Yeah.
The surface marking of the tumor and the incision and all that?
Right, we're able to see it.
Yeah, thanks.
Okay, so we've got a straight incision that should incorporate both those tumours. It doesn't go below the zygoma. It's nice. It's a nice incision. Yeah. Okay, good. Rightio. So now we just go ahead. I'll go and scrub if someone can infiltrate. Infiltrate, prep. And can you make sure some of the prep goes in the ear? Yeah. Hold on to them for me. I'm not going to wear them during the operation. Seven and a half.
Right, for the students here, they've just used the navigation system and the map of the tumor, which was generated by the Connectomics software. And they've delineated the surface marking of the tumor. And as you can see, it's a very simple linear incision, which should be able to give us a craniotomy that encompasses both parts of the tumor. As Dr. Theo has described, it is like a dumbbell-shaped tumor with a very small fringe of tumor tissue between the two. So they're just marking now and infiltrating with some local anesthetic. They'll complete the scrubbing, painting, and draping soon, and then we can be underway.
Dr. Nishit?
Yes,
Yeah,
yes, sir.
you could just tell the delegates there that we can take a small break by the time we do the scrubbing and draping.
Right.
Right? Tea and come back.
Yeah. It'll probably take about 10-12 minutes to finish prepping and draping the patient, so maybe even 15 minutes. So if anyone wants to take a break, have some coffee and tea.
Thank you. Thank you. No, it's okay. I can see it. Yeah. Okay, I'm ready for some pickups. Oh, no, I like it. Yeah, I like it. You like it, Karen? You should like it too. We're about the same height.
Nishit, can you hear us?
Yes.
Yes,
Yeah,
sir.
yeah.
We can see the
So,
operative field.
Yeah. So Theo's going to start off now.
Okay.
Yes. Yeah, pick 'em up. Okay, so I'm just going to do some fine. No, don't let go of that. Just going to take this stuff off.
Nishit, let us know how good the field is. Are you okay there?
Yeah, so it's it's a view from the side. It's not
Yeah.
like dead on from the top.
We'll increase the height.
Yeah.
Do we have any undergrads in the audience?
Yes, sir. We do.
Okay. So maybe you can brief them
Right.
about the temporal lobe anatomy a bit, and maybe the bony framework through which we are going to go.
All right.
Yep. Okay, we're ready to start, I think. Here we go. No, take hands off. Bobby?
So we are just in the skin level of skin,
Right.
giving a vertical skin incision.
Right.
So I guess when it comes to temporal craniotomy, and I would say any craniotomy for that matter, there's always a difference in the approaches, difference in the way the flap is raised. Every single step can differ based on the the case at hand. So here, Theo is an expert in the minimally invasive keyhole surgeries. So here's a flap which is very, it's considered as the most least invasive, I would say, because the standard incision that anybody would consider the Falkner incision or the question mark incision. So here we are trying to reduce the exposure by making a vertical incision rather than a question mark incision.
Okay, so what I do here is just suck smoke if you like. I try and preserve the SCA just in case. I always do that just as a bit of an exercise. Not absolutely necessary, of course.
The STA, superficial temporal artery. Is it possible to get a a view from above?
Okay.
We'll soon have the microscope, so that's okay.
Take a pair of scissors, thanks. There we go. Leave that so. You want to help me, don't you, Parent? Don't help. What so you want to need you? Bobby?
So the lower limit of the incision is a zygoma, and that would be a major landmark for us for this surgery, because the tumor is in the middle cranial fossa floor base. So a little bit of skull base approach is there as well here. A pretty interesting case because the glioma is involving the inferior temporal gyrus as well as the the occipitotemporal gyrus. So the entire focus is going to be onto the skull base.
Right, Paul? Okay. Oh. Oh. get into the glioma. They're too pointy. See if you can get some.
Nishi, is the view good there?
Okay.
Yeah, it's a little better.
Yeah.
Dr. Theo is just making an incision through the temporalis.
Muscle now.
Right.
Oh, thank you. Nice. Just make sure it's on blend. Burning and cutting. Make sure it's on burning and cutting. Wow, you guys injected a lot of local anaesthetic in this. Good. Very good. Not going to have any pain. The most local anaesthetic I think I've ever seen injected in the wound. Now, as you can see, I don't like the sucker. Remember, the sucker is your dirtiest and most dangerous instrument. So don't use them unless you absolutely have to. Dab it with some. Dab it with stone.
I think so. Yeah.
See, you're just about to suck again. Don't do that. Sucking causes bleeding, damages things. Oh, beautiful. There we go. Now we're down through temporalis muscle. It took us a long time because it was just so waterlogged with anaesthetic agent. I'll take a periosteal elevator now, thanks. Yep. Now, Mefty says that if you scrape the temporalis off from inferior to superior, it reduces the damage. Oh, we'll get that sucker out of there. Chandra, get that sucker out of there. Can you tighten that a little bit for me? Give me the periosteal back again, thanks. Okay. And get the bovine and just cut that a little bit. Beautiful. Yeah. Beautiful. Can't feel the zygoma yet. Oh, yeah, it's there. It's good. That's nice and low. So I just felt the zygoma. Just make sure I'm nice and low. I want it to get nice and low. Yep, we should do a little bit more than that now. Very nice. Look at this. Beautiful.
Dr. Theo, if you could just reorient our audience to which side is up
sure,
and down.
Sure. Hang on, just wait. Absolutely. Okay, good. Tighten it. Got it? Beautiful. Okay, so what we've done here, periosteal. So the ear is here.
Right.
The eye is here. Top of the head here. And zygoma here. And if I put my finger in, I can just feel the zygomatic arch right there. So what we've done is a stripping of the temporalis muscle to expose the skull base and and superiorly to get that superior tumour. So what we're going to now do is get the pointer now. We're just going to make sure that our craniotomy is going to be big enough. If you can get the pointer, that'd be nice. Okay, and I'm just going to make sure that I'm high enough. There, can you just make sure I'm high? Am I high enough? I don't have my glasses on. Can you get that closer for me? Okay. I don't have my glasses on, so I can't see, but just aim it towards me. And, oh, gee, that looks like it's plenty high. Am I registering? Is it seeing it? No, it's not seeing it yet, is it? No, it's not recognised. Oh, I see. Look, maybe that light's in the way. Move that light up and aim that up a bit. Can you aim the camera up a bit?
And I think the frame is...
Aim the camera up. That camera, aim it up a bit. Yeah, lovely. Okay, look, that's nice now. Okay, so we want to be this high. We want to be as high as...
Your hand is covering that frame.
Oh, that's what it is. Okay. So there's the tumour, and we want to be that high, and no higher than that. So, yeah, looking good. It's a good craniotomy. Okay, thank you.
Nishit, was that clear?
Yes. Yeah.
Okay, I'll take something to make a burr hole, thanks.
So what we can appreciate here is a small craniotomy that's going to happen.
It's actually a big craniotomy. Because it's two
for a minimally invasive neurosurgery.
Compared to the regular temporal craniotomies.
It's two craniotomies. Normally the craniotomy is about the size of your fingernail. This is going to be quite a big craniotomy, probably 3 times bigger than I would normally do, because we're going to expose both tumours through the one craniotomy and the normal tissue in between.
Yeah.
Okay, thank you. And I'll take the cutter now, thanks. Yeah. Take a big wash now, thanks. Okay, now can we put some drapes around here to make it clean? Rightio, so we've got a nice bit of dura exposed, brain's not too tense. Okay, I'll take the dural openers now, thanks. Oh, nice, look at that. No, no. Just give me a 15 blade and some nice small pickups. Oh, look at them, thank you. Thank you. That's right. Very nice, thank you. Okay, good. Right here, we're just going to open the dura now. Okay, I'll take the scissors, thanks. Are you showing this one? And you can open the other way for me. Let me just stop that bleeder. I'll take the bipolar, thanks. No, don't go on until I say. Okay, on. On.
Someone's blocking the camera. Yeah.
Okay. Go the other way for me. All the way up to here. Nice straight line. Beautiful, beautiful. Conditions are very good. The brain's not too full. Full enough where there's no shift, but not too full where it's bulging out. We'll take some stitches to stitch back the dura thing. Okay,
So they're just taking a stitch on the dura to retract it.
Yep, this is a dural stitch. We've opened the dura, and this is just going to clip here. Here. Cut. Oh, the brain's abnormal, as we predicted. And another stitch, thanks. Right at the tip, if you don't mind. Right at the tip. Oh, look how abnormal the brain is. Stitch. Quick, quick, quick. We don't want the brain to shift too much. Come on. You should have had stitches ready. Deeper. Deeper. Okay, put a hemostat on that for me. All the way at the tip. Thank you. Cut. Last one. Okay, good. Thank you very much, Stephen. I'll take some irrigation, and I'll take a smaller sucker if you don't mind. Maybe a 9 or a 7. I don't know what that is. What's that? On. And then what I'll also do is take some irrigation, please. So, yeah, that's nice. Some big irrigation, thanks. No, big one. Okay, so to the untrained eye, you probably can't see much, but to the trained eye, that is tumour right there. You can see it's very pale. Well, you can't see. Unless you knew what normal brain looked like, you would probably think that's normal. I'll take the bipolars. Thank you. Okay, but that's very, very pale there. Very there, and so the bottom tumour, of course, we know is down there somewhere. But we're going to do this one first to give us a bit of room. And I'm going to get the frameless stereotactic guidance just to make sure that what I'm seeing is tumour. And can you get rid of the offset? Get rid of the... And can you magnify that image a little bit for me?
Can we go to PIP with, yeah, thank you.
Yeah, can you? Thank you. Okay, so according to the pointer, well, according to me, I'll tell you where the tumour is. That's right in the middle of the tumour. Oh, that's right in the middle of the tumour there. That's good. And that's the upper limit right about there. So that looks perfect. And the back limit of that tumour is probably back there somewhere. Yes. Okay, and the anterior limit of that tumour is probably about there. So absolutely what we thought, this is all tumour here. And remember, the bit of tissue that we want to try and preserve is down there somewhere. Okay, good. Rightio. So now we're going to use a microscope and we're going to take this tumour out. What kind of microscope is it? Oh, great. I'll push it in. Yep, thank you. Thank you. Thank you. Okay, stop there. Thank you. And can we go the light all the way up, or whatever you have it on, 70% or?
No, 100.
You have it on 100, do you? Okay, I'm going to put it on high magnification and tell me if focusing for me is focus for you.
Right.
I just want to make sure that... Because I wear glasses, so I might have to change my lenses a little bit. I'll tell you when I'm focused on the little vessels.
Right.
We'll switch the video in a bit. 1 second.
Okay, it's focused for me there. How is it for you guys?
Yeah, we're just connecting the microscopes up. So another
Is
2
it
minutes.
focused for you guys or not?
We're going to focus the microscope now.
That's pretty good, actually, isn't it? Pretty good. I'll take the
Yeah,
Yep.
we got it on the screen now.
Correct. Could we have some orientation again? Inferior, superior.
Bipolar. Bipolar. Are these the fattest ones you've got? No, fatter. If you've got them, fatter. This is superior,
Right.
inferior,
Mm-hmm.
posterior, anterior.
Okay.
And this is tumour, obviously, here. That's normal gyrus right there. They're the fattest ones you've got. They're terrible. They're too pointy. No, I don't think. If you want it, yeah. Okay. They're the thickest ones you've got, is it? Oh, they're terrible. Terrible, isn't it? Okay, Shabri wants to show you the networks. So we're going to add the networks onto the frameless system. You can add them all on if you want to, Shabri. Which ones? You can add them all. Yeah, add them all if you want to. Yes, please.
Dr. Theo, how are you able to discern the abnormal brain for the students over here?
It's a little bit paler.
Right.
So think of that. That's normal there, okay?
Okay.
Okay, that's normal. It's yellowish with a lot of blood vessels. This is paler and less blood vessels and swollen. So
Right.
that is tumour and that's normal brain.
Okay.
It's subtle, but it's real. I'm going to put the navigation in now and you'll see that in fact... Oh, really? Sure. See if you can... Okay, that is the superior portion of the tumour, hopefully. Yes or no? Yes or no? Shebri?
Yeah, it is.
Okay, good. And this is the anterior part of that tumour, the superior one? Yes or no?
That will be a superior here in navigation.
Yep, good. Okay. And this is the posterior part
Yeah,
of
that's
it here.
posterior, right?
Yep, good. Okay, there we go. Bipolar. Right, so we've defined the tumour both with imaging and with gross macroscopic appearance. Now we're just going to go around here and take this one out. On, thanks. On. Keep it on. Just keep it on. These are terrible bipolars. This is for aneurysm surgery and stuff. This is not for glioma surgery. Look at that. And look, stop. Look how bad it is. Look how much is exposed.
Right.
And so as I'm concentrating on the brain, watch what happens. On. Look at that. It's burning the muscle. Terrible bipolars. On, thanks. On.
Dr. Shabri, if the isocool forceps are there, maybe those...
On, keep it on. Just keep it on. You guys, you need to get glioma bipolars, the TO bipolars. On, thanks. Give me a 15 blade, thanks. You can't do glioma surgery with subarachnoid bipolars. You need glioma bipolars. Yes, the TO bipolars, yeah. Bipolars. On, thanks. Just keep it on. And these are clear, this is clearly tumour already. Remember, tumour will bubble and melt. Watch as I bipolar. On. See it bubbling? Normal brain never bubbles. Keep it on, just keep it on. Oh my God, these are the world's worst.
Can we go to the PIP with the microscopic field enlarged?
Yeah, we can switch to microscope now.
Yeah.
No irrigation, no irrigation. I'll tell you when I want irrigation. Oh my God, these are terrible, terrible. On. Micro scissors, thanks. Micro scissors. Grabbing forceps or Russians or something to take this tumour out. Grabbing forceps or tumour forceps or Russian forceps. Got anything bigger than this? Anyway, that's all tumour. That's tumour. Got a bowl or something? No frozen. It's okay. Not going to change our management. Save some money. Okay, bipolar, thanks. And I can tell that this is tumour because it's so tough. See how I'm sort of pulling on it and the whole thing moves? Normal brain never does that. Put it in the bowl. Put it in the bowl for me. It's got fluid in it, hasn't it? Yeah. See how that? See how the whole brain moves like that? That's tumour. Okay, bipolar. And watch it melt now. Watch it as it bubbles. On, thanks. Watch it now. Look at it bubbling away.
Right.
Oh my God, these are the world's worst bipolars. It's so much exposure and it's pointy. Oh my God. You must have some fatter ones in this, surely. Keep it on, just keep it on. And did you hear it? Did you hear it go up the sucker?
Right.
It sounds different. It sounds like mucus. Okay, give me those big graving forceps now, thanks. Come on, where's the bowl? Every time you give me the graving forceps, you should also have the bowl ready. Okay, thank you. Okay, now let's start defining some edges here. Here's a sulcus here, right here's a sulcus. Put a patty in there for me. On, thanks. On. On, keep it on. Keep it on. Thank you. On. Oh, these bipolars are terrible. On. Keep it on. Just keep it on. You can see that I'm clearly still in tumor. Focus down for me a little bit with the microscope. Keep it on. Don't go off. Keep it on. Okay, stop there. Now, did you see those petechiae appearing there? So I'm getting close to the edge. And not only that, you could see the edema coming in as well. So those little petechiae are normal, not quite normal, but almost there. Bipolar.
Would that be the sliver of tissue which we were discussing, sir?
Sorry?
Would that be a sliver of normal tissue between the two?
No, that's down there. That's up there.
Yeah.
On, thanks. On.
This is anterior, right?
It's still
Sorry,
burning.
this is posterior.
Posterior, yep.
Yep. Okay.
Oh, okay, that was normal brain. So did you see that that did not bubble and instead it charred? Let me just show you that. Okay, so I'm going to show you what normal brain looks like. It charred and doesn't bubble. Get ready? See how it's a bit black? See it's black? That's normal brain right there.
Right.
Okay, bipolar. These bipolars are just, I can't tell you how bad they are. They are so bad. Look, they're exposed all the way up here so you can burn blood vessels without even knowing it. On, thanks. On. That's tumour. That's normal. See that? Didn't bubble, it just charred. On. See how that bubbles? That's tumour. 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 Tumour, focus down for me. Focus down for me. Focus down for me, somebody. Somebody focus, I'll do it myself. Take this, take. You obviously didn't understand my accent, but I was just saying focus for me. Okay, wet the whole brain. Give me the bipolars. Wet the brain for me. Okay, stop on. Just keep it on. Clearly tumour. Clearly tumour. Clearly tumour, still bubbling away. Still bubbling. Still bubbling away. Still bubbling away, even exploding.
Pariche, could you focus, please?
Yes, by all means, you focus for you if you like. Take this. Okay, we're getting close. I reckon it's going to be here somewhere, the interface. Pretty close to this. Wet the whole brain, thanks. On. On. No. Yes. No. Grabbing forceps, tumour forceps. And have a bowl ready to put it in. Bowl. On things. Scissors. On. See, everyone can see that, can't you? That's tumour. That's bubbling. Okay, now we're getting close to normal. Getting close to normal. Not there yet, but getting close. That looks like it could be tumour as well. On, thanks. This could be that connection between the two tumours. Focus down, focus down. Keep going. Stop. Look at that. Everyone saw that, didn't you? That was normal. You saw it char. It didn't bubble, it charred. Okay, so we know we're right normal right there. And not only that, look at all the little petechiae are starting to appear as well. That's normal grey matter there probably. On, thanks. Tumour. 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 And normal brain. See that? Focus on the normal brain there. That's normal. See the petechiae appearing? It's normal brain there.
Yes, sir.
Right there, that's normal brain right there. On. Clearly tumour there. And that's, again, this is a connection between the two tumours happening here. Okay, on. And now the edema's coming out. See the edema? See that? Stop. Stop. See that? Normal brain. See it char? It didn't bubble, it charred. On. Normal brain. Keep it on, keep it on. Emma. Oh, these bipolars. Look at that. See how I burnt that vessel without even knowing it? You've got to get a pair of glioma bipolars. It's ridiculous. How can you do good surgery with those terrible bipolars? Okay, bipolar things. On things. See that? Completely normal. On. Normal. Tumour. Tumor. 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 That was beautiful irrigation just when I needed it. Sulcus. Focus down, focus down. No irrigation until I tell you. No. Focus down. Scissors. Bipolar. On. Scissors. Bipolars. On. This is a clearly tumour here. Watch it bubble. Watch it bubble. Clearly tumour. On. See that? Keep it on. Just keep it on. Clearly tumour. Clearly tumour. Obvious tumour. Sulcus now coming up. Look at it just bubbling away. Keep it on, keep it on. Okay, focus down a bit for me, focus down. Just keep it on, keep it on. Scissors. Bipolar. On. Keep it on, keep it on. Focus down. Focus down. Beautiful. Beautiful. You hear it burst and bubble?
Yes.
Explode? That's
Yep.
tumour. Normal brain will never do that. Not even a Demonis brain won't do that. Okay, you can start to come to normal. You're getting close to normal. Stop. How do I know we're getting close to normal? Look at the petechiae. See the little petechiae?
Right.
Takes 1 or 2 seconds. And see all the edema coming in? You know you're at the edge when the edema starts falling in. Okay, so you're starting to get close to normal here. We're not quite there, but we're almost. I reckon that's a bit of normal brain right there. On. See that? It charred, that's normal. On. Yeah, focus it so it's focused for you. Keep it on, keep it on. Wow, look at that. Look at that. See that? Normal. See that? Normal right there. On. On. normal, normal. Take this. God, those bipolars, I can't believe you operate with them. Just so much exposed. Just can't lean up against anything. On. Normal. This is tumour here, and that's normal there. On. That's normal grey, that's normal white. See that? Look at that. See that char? And as opposed to this, watch this. On.
Mm-hmm.
And you heard it? Did you hear it go over the sucker then? Sound like mucus. Like this. We're almost at the edge here. With the whole brain, please. Bipolar with the whole brain. With the brain. On. With the brain. With it. With the whole brain. With the whole brain. On. Never. Virtually never. Yeah. It's all, there's brain shift now. It really isn't that accurate. And you've got the roadmap mapped out in your mind anyway. Oh, oh. Off. Try and preserve that sulcal vessel there. Give me a patty, thanks. I'll take it, thank you. We can try and preserve that sulcal vessel. You can probably sacrifice it, but on. Turn my suction up just a little bit, please. Turn my suction up a little bit. On. Take this. Give me the wash, thanks, to me. Just give me the wash. I think you can all tell that's normal brain. It's nice and white. Petechiae.
Mm-hmm. Yes, sir.
And I think you can tell that that down there is still a bit of tumour. Right there. In fact, there's that cyst that we thought we'd see. Right there, see that? On. I'm sorry if I'm wibbling. It looks like my arm's unstable because I can't rest it on anything. Because if I rest it, the bipolars lean up against the brain and it burns the brain. These are ridiculous. Ridiculous. On. So you can't rest your hand on anything. Focus down. On. Normal brain there, normal petechiae. Showering. Look at that. Oh, see that? That was just a perfect demonstration. See the petechiae? It takes a second for it to appear. Ready? That's normal brain right there. It doesn't get any more normal than that. On. On. Oh, look at that. See? See it char? On. Charring. Done. It's done. That tumour's done. Now we're going to go find the other one. Did everyone appreciate that? That we're at the borders now?
Yep.
I'm going to give you a really good macroscopic view of that, and you'll see pretty clearly what normal brain looks like. Give me the irrigation, thanks. Look, see the white background, petechiae.
Yeah.
100% normal. Okay, now we're going to go down here and get the other one. And hopefully maintain the tissue in between. Give me the pointer. I just want to see that I'm in the right direction, heading in the right direction.
Can we get a PIP of the imaging, please?
Okay, I think the other tumour is down here somewhere. Am I right? Is that the tumour there?
We're unable. Yeah, got it.
Is that the tumour down there?
Yeah, yeah.
Can you freeze it so I can have a look myself? Is it frozen? Can you hold it for me? Yeah. Don't hit the brain. Oh, what's happened?
It's frozen.
You just go back to normal view. Don't worry if you're holding it. There we go. Oh, look at that. That's perfect. Look at that. Perfect. So everything is below. Yeah, below that. Inferior to that. Okay, great. Thank you.
So if you,
So this is the top edge of the next tumour, and we knew that. We knew that it was going to be hidden underneath the skull base there.
we will be preserving this.
Okay, bipolar, thanks. And give me a bigger patty than you gave me before. Thank you. Okay, on, thanks. Oh, we're in tumour already. On. Oh, see a bubble? You see a bubble?
Yes.
On. Off. On. Is this? You do appreciate what I'm saying about those bipolars, don't you?
Yes, I mean.
Yeah, because look, if I try and balance my hand on the edge, I'm coming at this angle, and I'm just going to burn all this brain that I don't want to burn. On. You need to get the TO bipolars and you'll be able to do, we'd be finished this case by now. The TO bipolars. Wet the whole brain, thanks. Wet the whole brain. Wet the brain, on, thanks. Wow, that's still tumour clearly. Keep it on, keep it on. Focus down for me. Focus down. No, more. Stop. Off. On. I don't like this. This is looking a little bit more aggressive here. And take a biopsy of this and tell you it's the most aggressive part. On, thanks. Yeah, give me the tumour grabbing forceps, thanks. It's more discoloured here, see that? Yeah, I'm not happy with that. That looks like grade 3 actually. Gee, I'm sorry about that. Could be grade 2 still. Oh, look at that. Look, it's soft. Oh, no. That looks like the aggressive. So write this down as the most aggressive part of the tumour. Give me them back. I'll take them back again. No, I'll take the grabbing forceps back.
So what would be your opinion about the grade of the tumor by looking at it?
Well, that top one was grade 2, and this one looks like it could be grade 3 or
Probably, yeah.
possibly even grade 4.
Yeah.
Wow, that's bad. It looks, look at it sucking up.
Yeah.
Bipolar.
This part of the tumor looks a bit more vascular than the earlier one.
Yeah, a little bit more vascular, a bit more discoloured. On. Yeah, I don't like the look of this at all, I'm sorry. Oh, look. No, this is definitely not a grade 2. See vessels yet, so that's good. Normal brain there, see that?
Yeah.
Take this. I'll take the stool to sit on now, thanks. Thank you. Thank you very much. Okay, on things. And this goes all the way down the skull base, so. Oh yeah, it's tumour, on. Focus down, thanks. Thank you. Wow, look how nasty this is. Oh, nasty. I've got the Zeiss. Yeah. One thing. Yeah, this is nasty tumour. Just keep it on. If I had my bipolars, I'd have that stop. That bleeding would have stopped ages ago. No, that's okay. Focus down. Down, 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 down. Yep, that's good there. We're at the skull base now. Really, really obvious tumour. There's the skull base right there. Really, really obvious tumour. You can see it. Everyone can see it, can't you? It's all just bubbling away. Focus down. I'll take it. I'll take a scissors thing. Scissors. We're trying to find the anterior margin now since we've got good decompression. I'm just going to go in there and find the anterior margin. Okay, on thing. Oh, that's still tumour. Focus down. Focus down. Starting to look normal now. Here's scissors. Focus down for me. No, worse. Stop. On. Scissors. Focus down for me. Oh. Bipolar. On. On. Take this. How do I do it? Oh, look at this. How comfortable is that? I'm sort of stuck. The chair's not moving. Yeah, unlock it. Yeah, don't lock it. Unlock the chair. Yeah, thank you. Can someone else press it then? Someone else press it. A chair down, chair down. No, it's not going down, but it'd be good if it would. On. Oh, the microscope just moved. On. Off. On. And focus down for me. On. Focus down for me. No. Worse. A little bit more than that. Good. Ah, yes, thank you. No, it's going up now. It's going up. Go down. Go down, go down. It went down and then it went up. Oh, it's going up. Yeah, keep going, keep going. Yeah, nice. Keep going, keep going. Okay, stop it there, thank you. Leave it on. On. Oh, this is beautiful, beautiful. I'll take this. And you can see all the edema coming out. The edema doesn't come out unless you're right at the edge of the tumour. Okay, thank you. Yep, yep, do it. Thank you, that's nice. Thank you very much. Okay, bipolar. On. Focus down again for me. No. Down, 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 down. You're going the wrong way. Good, stop there, that's good. Scissors. Oh, look how malignant this is. See how nasty it is? Sucking up with the sucker. Bipolar. Not yet. Get rid of all those strings. On. Focus down for me. Okay, I'll take that petty now thing. take that patty. Give me the patty. Okay. The large running bone. I don't know how you stop bleeding with these bipolars. You guys must be so skillful. Like skilled surgeons working with such terrible equipment. Imagine if you had good equipment. Imagine what you guys could do if you had good equipment. On thanks. Sometimes. We're right at the edge of normal there. You can see that, can't you? How can you stop any bleeding with these bipolars? Oh my God, how can you stop bleeding? Look, every time you go to stop that bleeder, there's points. No, don't worry, I'll use them, but I mean just absolutely terrible. Bipolar? No, these are bad, but I'll use them. Yeah, have you got one better than this? Oh, if you got one. No, not until I say. On. See, if I had my bipolars, I swear I would have stopped that hours ago. On. Normal, you can see that's normal. See the petechiae? Saw the petechiae, you saw them. Bipolar. On. Tumor. Give them a good clean, thanks. They were given to me dirty. That's very bad. Very naughty. Okay, that's normal brain there. See that right there? You can see that, can't you? Normal brain there. On, thanks.
Yeah.
Normal brain there. See that char? See a char?
Yeah. Yes.
Normal brain there. Probably a bit of tumour here. Let's on. Yep. Yep. No, tumour there, see that? Clearly tumour, on. You can see that tumour, can't you? Scissors. On.
Dr. Nishit.
Yes, sir, tell me.
Yeah, you can ask the audience if anyone has any questions.
Sure.
Or are they following what is happening inside the OT?
Yes, sure.
I think this is normal. I'm not quite sure. Yeah, it is, I think. Give me a medium patty, a big one.
Hello.
Yeah.
Nishit, you can hear me?
Yes, sir, we can hear you.
Yeah, so there were two different corticectomies were done. And the island of normal brain, which before the surgery started, Professor Theo demonstrated
correct.
certain networks were probably present in that part of the brain.
Yes.
That island is left and two separate corticectomies have been done.
Correct, sir.
And this is the lower part of the tumor that is being removed, which is extending down to the temporal skull base, middle fossa skull base.
Right. I think at the end of this, we'll again use the navigation and it'll become even clearer to students over here.
So based on the consistency, there was a change in the consistency in the two parts of the tumor. The lower one, which Professor Theo is operating right now, seems to be of a higher grade, probably a grade 3.
Right, sir. It's
So
a lot
if
more
you can
vascular.
observe, it's a lot more vascular.
Look. Look.
Yeah.
Thrombosed vessel. You see that? Everyone see that?
Yes, sir, we can see that.
That's not a good sign. Focus on that thrombosed vessel. I'll focus on it. Take this. Yeah, not a good sign for this poor guy. That was a thrombosed vessel. Right there, look at that black thing there, see that?
Okay.
Focus on it. A bit more.
30-40 windows are open, sir.
Keep it on. Take another medium patty, thanks. Take. Not yet. Don't put it in my way. I'll take it. Okay, on, thanks.
Any of you have any questions?
Still tumor there. Still tumor there. Got to go further back. Take this. Wet the whole brain thing. Wet the brain. On. Still tumor there. Focus down. Focus down. A little bit more. Yep. Move it on. Scissors. Okay, getting close to the end. Good. This is the last bit here now. Give me a medium patty, thanks. Medium patty. Sometime soon, please. Yep. Okay, on. Scissors. On, please. Off. Give me the irrigation, thanks. Follow. Follow. On. Off. It's the last bit here now. On. Clean them. Give me the irrigation, big irrigation actually. Focus for me, down again. Clean them. Clean the bipolars. On. Clean them again, thanks. On. Scissors. Follow. On. Almost. I'm sorry it's taking so long. If I had my bipolars, we would have finished 2 hours ago. I swear these are the worst bipolars I've ever used in my entire life. You guys, I don't know how you do this surgery. Oh, thanks.
It's been a wonderful demonstration of your skills, managing with them.
Well, you're the ones that should be commended because you take out tumours using these ridiculous bipolars. Aim them, thanks. Okay. Give me a medium patty, thanks. Oh, no, I've got one. I've got one here. No, I didn't say on. Give me a medium patty, thanks. Medium patty. On. On. Look at that. It was burning everything but the vessel. It burned the patty, it burned everything except the vessel. That is crazy. Give me the irrigation. Just show me that vessel. Yep, irrigate for me. Okay, let's see if we can burn that vessel. On, thanks. On. Keep it on, keep it on. Off. Give me a clean medium patty thing. Focus down a bit. Stop. I think that's a little bit of tumour right there. Let's try it. On, thanks. Yep. Keep it on. Keep it on. Off. Take this. That looks like normal there. See the petechiae there? That looks like normal there. That is normal there, and that is tumour there. Can everyone see that? On, thanks. The last bit of tumour there. Oh, that was normal there, and there's the ventricle right there. On. Keep it on, keep it on. And remember, we knew that it was going to go through the temporal stem up into the insular region. Not quite up there, but you know, it's getting close. Off. That's all normal there. And that's tumour right there. That's ventricle right there. No. Bipolar. I think you can see that's tumour right there. Right there's tumour. On, thanks. Oh no, actually I was wrong. That's normal. On. It's normal. Normal. Okay, I think we're almost done. Give me the medium patty, thanks. Take this. Back. Bipolar. On. Off. That's enough, that's enough. That's enough, that's enough. On. There's tumour here, obviously. Normal brain there. On. Scissors. Okay, that's tumour. Give me the big irrigation, thanks. Give me the big irrigation. Okay, we'll take a Valsalva now, thanks. Valsalva. Bipolar. On, thanks. Oh, don't do it quite yet, sorry. On. I just found a little bit more tumour, so hang on. 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 Off. Sorry, I just found a little bit more tumour. I'll be finished soon. Medium patty, thanks. On. Normal. Normal. On. Tumour. Normal. Tumour. On. It's okay. Yeah, it is better, thank you. Off. This is the link between the two tumours here. I believe this here. On. Off. On. Off. On. Off. No, I'm going to do it in a minute. This is the link between the two tumours here now.
Right, sir. That's the, yeah. Okay.
On. Off. See right there, see that?
Yeah. It's connecting the two cavities, correct?
Yeah, but we maintain the normal brain in between, see that?
Mm-hmm.
Okay, we're done. We're done, I think. Let me just zoom out. We can if you want to, but it's all shifted. Everything's shifted. Big wash, thanks. Okay. Big wash, thanks. Bipolar, thanks. Oh, you can get it over. Thank you. Some more wash, thanks. More wash. Take that patty out for me, thanks. Take the patty out. Take that patty out. Do it nice and gently. Some more wash. Some more wash. Wait, I'll wash it. How come it takes so long to get me wash? Okay, go. Out. Yeah, take that. Some more wash, thanks. Oh my God, it takes so long to give me that wash. By the time you give it to me, it's all bleeding again. Give me some wash, thanks. And get ready to give me, as soon as I give it to you, give it back again. Fill it up and give it back again. Okay, medium patty, thanks. No, I'll do it. No wash, I'll tell you when wash. These bipolars are so bad, I won't be able to bipolar them unless I come from this angle here. Give them to me so I can use them. Give me the bipolar so I can use them. Like that. On. Oh. On. On. Keep it on, keep it on. Off. On. On. Oh my God, it burns everything. Look, it burns everything except the vessel. I'll take a bit of, what have you got? Have you got some hemostatic agent like Surgicel or gel foam or something? On, thanks. On. On. Oh. God, they are the worst bipolars in the absolute world. Look at that, a whole centimetre exposed. That is ridiculous. It's just ridiculous. How do you guys use them? How do you do it? No, it's okay, it's okay. Give me a big wash, thanks. I reckon you guys are the world's most skilled surgeons. So it's easy to operate when you've got good instruments, good tools. When you've got to when you've got to operate with bad tools, you've got to be extra skilled. How nice and dry is that? Okay, now we're ready for a Valsalva, thanks. Big wash again, thanks. Yeah, we're ready for a Valsalva. Up to 50, thanks, 50. Beautiful, beautiful, that's good, that's good. Yeah, that's good. Okay, looks good, right, let's give me the pointer and we'll show people. I don't know why we're doing this, I wouldn't do it, but if you want me to do it, I'll do it. So look how much shift there is. There's about a half a centimetre of shift. Why are we doing this? Okay, rightio. So, why are we doing this? Yeah, no, we're not. It's ridiculous. You know, everything's moved. It's not going to show something. Okay, big wash, thanks. There we go. Lovely. Okay, we're done. Can you close for me? Did you like that? Did you learn something?
Nishit, am I audible?
Thank you very much.
Anybody in the audience?
Yeah, yes, sir, we can hear you.
So basically, we're not doing the navigation at the end of surgery because of the
Brain shift.
The brain shift.
Yeah.
It's not. It won't really help us.
Mm-hmm.
So, but then it immensely helped during the surgery to know the relation with various networks we were discussing.
Yes, sir.
And of course, we were able to take off, both the sections of the tumors with a small craniotomy.
So we did use navigation after the first corticectomy and like the first half of the tumor resection.
Yeah.
So there would have been some brain shift then itself.
No, but intraoperatively we could make out the differences very well. So to complete the surgery.
Correct.
Yeah.
So
and then of course various anatomical landmarks that he was demonstrating.
Mm-hmm.
Yeah.
Mm-hmm.
So if there's any question that the audience would want to ask, we can take it now.
Yeah. Anybody have any questions? They seem to be very, very happy with the discussion and understood everything. So, any questions about how they've gone about things? Right. Thank you, Dr. Theo, Dr. Shabri, Dr. Paricha, and Dr. Rakshit.
Thanks, Nisha. Thanks.
Yeah.
Check. Hello. Check. Test. Check. Hello. Check. Check. Hello. Check. Check. Hello. Test. Check. Hello. Check. 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 Betul. Check. Hello. Check. 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 Hello. Check. Check. Right. Right. Right ಇದೆ. ಕೊಟ್ಟ ನನಗೇನು ಗೊತ್ತು. ಸರ್ ನೋಡಿದ್ರಾ? ಓಕೆ ಸರ್. ಹಾಂ ಸಾಕು ಸಾಕು. ಕೇವಲ ಹಾಕಿದ ತಕ್ಷಣ ನನಗೆ ಇದಾಗುತ್ತೆ. ಅದು ನನಗೆ ಗೊತ್ತಿಲ್ಲ ಕ್ಯಾಮ್ರಾ ಹಿಂಗೆ ಅಂತ. ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋ ಅಪ್ಪ ಈಗ ನೀನ್ ರಜೆ ತಗೊಂಡು ಅಭಿನಯ ಕೊಡೋದು ಯಾರು ಬರ್ಬೇಕು ಆಡ್ಸಿದ್ಯಪ್ಪ ಸರಿ ಬಿಡಪ್ಪ ಆಯ್ತು ಓಲಿ ಸರಿ ಆಯ್ತು ಬಾ ಈಗ ಅದೇನೋ ಹಾಕ್ಬಿಟ್ಟೆ ಆಡಿ ಹೆಂಗ್ ಕೊಡೋದು ಅದಕ್ಕೆ ಅದು ಆಡಿಯೋ ಅಡೆ ವಿಡಿಯೋನ ಬಂತು ಆಡಿಯೋ ಬಿತ್ತಿರ್ತಾನ ನಾನೇ ಹಾಕ್ಬಿಡ್ತೇನೆ ಇನ್ನೊಂದು ಇದಂದ್ರೆ ಇನ್ನೊಂದು ಕ್ಯಾಮ್ರಾ ಅಡಿಷನ್ ಕ್ಯಾಮ್ರಾ ನೀರು ತಗೊಂಡು ಅವನಿಗೆ ಔಟ್ ಕೊಡ್ಬೇಕು ನನ್ನ ಹತ್ರ ನೀರನ್ನು ಹಾಕೊಂಡು ತಗೊಂಡು ಮಾಡಿದ್ರೆ ಡೌಟ್ ಅಲ್ವಾ ಇದು ಡೌಟು ಆಯ್ತು ಇನ್ನೂ ಒಂದು ಊಟಕ್ಕೆ ಹೋಗಿರ್ಬೇಕು. ಊಟ ಗೊತ್ತಿಲ್ಲ ಸರ್ ಅಂತ. ಕರ್ಕೊಂಡು ಹೋಗಲ್ಲ ಅನ್ಕೋತೀನಿ ಲ್ಯಾಬ್ಗೆ. ನೋಡಿ ಬಾಕ್ಸ್ ಒಳಗಡೆ ಬಾಕ್ಸ್ ಒಳಗಡೆ wait. ಗಾಡಿ ಇರಲಿ 2 ನಿಮಿಷ 30 by 6 width, 30 by 6 double X width, 30 by 8 position front back fascia. Fascia is
ತಾಕಿದೆ ಬೆಳಕು ಹಾಕ್ಬಿಟ್ಟು ಲೈಟ್ ಹಾಕ್ಬಿಟ್ಟು
ಹೊಡಿತಾ
ಮೂಲೆ ಇದೆಯಲ್ಲ ಮರ ಅಷ್ಟು ಮುಂದ್ಗಡೆ ಇದೆ ಲೈಟ್
You're talking first, aren't you? Yes. So I just want to check owner of this. Just call him and check once. Okay. The mics are early. So how we ಹೇಳಿ lateral faculties are there. ಅಲ್ಲ ಅಲ್ಲಿ ಕಾಲೇಜಲ್ಲಿ ಬಂದಿರ್ತಾರಲ್ಲ ಯಾರು ನೋಡಿದ್ರೆ ಹೇಳ್ತೀವಿ ಸ್ಟಾರ್ಟಿಂಗ್ ಅಂತ.
basically, I think there's a CME talk going on Connectomics. I had posted in the group, if you remember, which is the pitch at 2:30. It's bonus round. So if you're free, please come. And you're called for what? The same thing? Or okay. Sure. Okay. Yeah. Okay. Okay. How old is that? How old is she? So then this brain city brain should be we just do a scan. Let's not ignore it. Because posterior part of the occipital may not be a region for migraine usually. So let's not miss out anything. May not be anything. But since she's quite young, let's try and do a scan, brain city brain. Yeah. Okay. If there is nothing else other than a headache, we can get away with just the CT. Because any other region, they will be, somewhat other symptoms. So nothing. So then we just do a plain CT, and if there is anything, any doubt in that, we can always scale it up. Because MRI has so many sequences, I will want to direct it towards a pathology. So that's the reason why I thought we do a plain CT. Okay. Yeah. 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 You can share the number. You can share. Sure. Sure. See. There is overall. So I should you principles.
Sometimes those chunks of settings changes a little bit. It may not be just it's just too close. So she should definitely speak to her. And if she doesn't want to speak to her neurosurgeon, we're at the good times. Just what we have to understand. I tried to call the when she didn't pick up. I called Felicia because I told her that she was going to call Telugu half an hour before we speak. So which ones are you looking at?
I had 58. 58. 94. Most of them good.
Do they really have problems? Never have problems at all.
I think no.
How much of it is normal?
It was really that problem.
Just going on the normal.
They had to the black piece. Can you connect him? No. I can connect. So that is the adapter. Can you explain the system? Pen drive. Yeah. Oh my God, happy birthday. It's a very good time. None of the physics are excellent. That's the best part. Just try to be there are two here nice. If I'm there, I'll do it. These are not around. So this is not only one picture, right? Only this one. So this is a big.
Welcome back. Now we have this one.
No, he's asking whether we are getting into it. See, he's looking at the only transcripts. He was asking whether it is retrograde procedure. He is not hypothetical. And when it is what?
But it's been for some 6-7 years. That's what it's all in the but nothing came up. And now it's beginning to get counselors coming to for because the YouTube video somewhere running to 7 years. Yeah, it's very old. It's very old. It's actually
ಹಲೋ ಹಾಕಿದೆ ನೋಡ ₹300 ಇವಾಗ ಎಷ್ಟಾಗುತ್ತೆ ನೋಡಿ ಹೇಳ ಮೇಲೆ ಮಾತಾಡಿ ಸರಿ ಆದ್ರೆ ತಗೊಬಲ್ಲ ನನಗೆ ಎಷ್ಟು ಬರೋ ತಗೊಂಡು ಹೌದಾ ಇಲ್ಲೇ ತಗೊಂಬರ್ಲ ಇಲ್ಲಿಗೆ ತಗೋಬಾ ಮತ್ತೆ ಯಾರು ಹೋಯ್ತಾರ ಪರೋಟ ಒಂದು ರೈಸ್ ತಗೊಂಬರ ಫುಲ್ಲು ತಂದೆ ತಗೋಬಾ ಇಲ್ಲಾಂದ್ರೆ ಕಂಪ್ಲೀಟ್ ನಾನೇ ಹೋಗ್ಬಿಡ್ತೀನಿ ಸರಿ ಚಿಕ್ಕನ್ ಬಾರ ಪರೋಟ ಒಂದು ಎಷ್ಟು ಕೊಟ್ಟಿದ್ದೀನಿ ಸರ್ ಈಗ ಇಲ್ಲಿ ಕೊಟ್ಟಿದ್ದೀನಿ ಕೊಟ್ಟಿದ್ದೀನಿ ಮಾಡ್ತೀನಿ ಸರ್
All right, well, welcome back everyone. I hope all of you enjoyed the session in the morning, the live operative surgery, and the case went well. The patient's been extubated also, so we'll have a look and then probably get a post-op scan tomorrow. And now I hope all of you have had a good lunch. Okay? This is on policy. Hope it wasn't too heavy. And we'll begin with the afternoon session, which comprises 3 talks. Starting off, we have Dr. Shabri, who is a functional epilepsy neurosurgeon, to speak to us about basically the fundamentals of connectomics, the physics behind it, and how to network in this particular field.
Yeah. So, check. Am I audible? No.
ಬರ್ತಿದೆ ಮಾತಾಡಿ
Check. So thanks for the introduction, sir. It's not complicated.
ಮಾತಾಡಿ
Okay. Am I audible now? Or can I have that now? Yeah. So good afternoon to one and all. So today we are going to talk about a very novel subject, not just for neurosurgery, and for the entire neuroscience, I believe, because we've come a long way from the basic MRI to imaging, which is going to tell us a lot about the brain's function and network. So if the brain were so simple that we could understand it, be this so simple that we couldn't. So that's the saying goes from the American famous physicist Emerson Pugh, which explains the complexity of the brain, where we took around 100 years to come, to be here to discuss about the imaging of the functional part of the brain, not just the structure. So I'll be dealing with the physics part of it, a bit about the principles as to how the connectome is different from the usual imaging of functional MRI or even diffusion tensor imaging, and how we are going to use it in various fields to help us understand the disease and even managing it. So it all started way back in 19th century, in fact, where Bahal and Golgi. It's a very famous, controversy between them when they proposed these two theories, with the reticular theory versus neuron theory. Uh, the rivals even didn't stop it. Even with they shared a Nobel Prize in 1906. So after that, that theory came up. German anatomist Corbinian Broadband, in 1909, he published a paper on Broadband areas, which all of us are familiar with. So, as Dr. Theo was mentioning, it came up with only 47 areas. So, we can see how the entire thing has changed over the next 100 years or so, and see that how the so-called silent areas has grown to an extent where every single millimeter of brain has some or the other functional networks, and how they are going to make a difference. So these were the limitations with the Broadman's brain mapping. Basically, it was based on the cytoarchitecture. It was purely based on the Nissl staining. So with that, there was asynchrony between the anatomy and function. In so-called discrete areas like Broca's and Wernicke's, we are going to see that how it grew beyond the areas which were limited by anatomical boundaries. The cytoarchitecture was more so like a world map where one cannot understand the geopolitical relationship where each cities can have. So that was the major limitation, and it obviously gave us a bird's eye view on the basic functions like speech or motor or visual. So we did not really comment, or we cannot really understand the higher cognitive functions that we're going to discuss now in terms of Broadband areas. And another fallacy was that it was entirely based on the gray matter, and the white matter bundle was not really given too much of a credit. So obviously there were a lot of inter-individual variations when these areas were considered. So obviously, and that knowledge to to extrapolate to your own individual patients is a big problem. So so the best example is, as I keep mentioning, is the language pathway. We all started with the localizationist view, saying that this is a Broca's area, that is one case, and that's it, nothing beyond it. So that is a very classical. Even in my undergraduate days, even now, I guess the classical teaching would be that this is Broca's and Wernicke's, and there are the discrete boundaries, anatomical boundaries. But then, obviously, that we figured out that there is something beyond just Broca's and Wernicke's aphasia. There is something known as transcortical aphasia. There's something known as conduction aphasias. So there are a lot of different types of problems and deficits we could diagnose, and then it came the associations view. And now the recent trend is the horological view. Horology basically means paths, various pathways. So now we are interested in the networks. So that is the trend now. So we are not just limiting ourselves with that particular area. Look at the language pathway. It started off with that, and you see almost I would say around 30-40% of the brain is involved in the language. So every centimeter of incision that we would make, like what you saw today as a corticectomy, we really have to think: are we going to disturb any network that are involved? So how do we know it unless we can see it, with our own eyes? All we can see during the surgery is this pink jelly, which is pulsatile, and other than that, we really can't. So in terms of functional networks, we are really blind. So today we're going to see how that has changed. So here, just trying to see, this is the basic principle. Many of your residents here and the undergraduates, the
imaging of the brain took a different level when a functional imaging came in. So the first functional imaging that was very popular, widely used, was functional MRI. So where the cortical areas were used to map out the brain and to understand which are the areas we are dealing with and which are the areas which are in close proximity to tumor. So here you can see how the neuronal function actually transmits, and that neuronal function increasing the oxyhemoglobin when there is an increased blood volume in. We know where the tumor is located in relation to the function, like motor hand function, for example. So that we are careful about it. So that was a very major advance in the imaging. So we could map out the entire cortical areas now using the fMRI, and it went on to become. This is a task-based fMRI, what I just mentioned. So the next advancement that happened was a resting state fMRI, where the subtle changes in the normal brain function that itself was picked up, and there many neural networks were identified using those subtle changes, which became a resting state fMRI. So I'll just show a brief video about the next advanced imaging, which is known as diffusion tensor imaging. So this was another path-breaking advancement which happened in the science of imaging of the brain. So this is the principle of diffusion that is being used. So we all know that MRI basic principle is the alignment of hydrogen ions into a resonance. So that energy is picked up in the magnetic field, and that is being shown in a grayscale. What we're seeing here is the diffusion of the water molecule along the length of the axon. So that principle has been used to identify the various tracks. So obviously that diffusion, if it can happen in an axon, so based on the direction of the axon, we can map it out. So that is the principle of the diffusion imaging there. So here you can see this is the voxel. So pixel is the two-dimensional term. Voxel is what we use in a three-dimensional MR imaging, where we can see the each direction is considered, where there's a fibers which are in one group of alignment, one direction, and then if there is a fibers which are crossing, there could be a perpendicular vectors that are moving in. So that is a principle where we can look at various fibers. So when we look at the voxels, there are 4 different voxels here, which is part which represent each millimeter of the brain. So where you can see one direction of axon and another direction of axon. So within within a centimeter of the brain, there could be multiple voxels like this. And then if you look at a close-up view of that, those individual voxels would represent ultimately the direction of the fibers. Okay, so there would be a corticospinal tract which is descending down, and there could be a corpus callosal fiber which is going across. So this is the principle of tractography here. So obviously it is very colorful. So that color coding in an RGB spectrum was given based on the direction of the axonal transport that is happening in the brain. So you can see the blue is for the craniocaudal fibers, and the green was for anteroposterior, red is between the interhemispheric commissural fibers. So that's how the tractography came in. So but then the disadvantage of tractography is that it's not really functional. It is more of a structural study that we're doing. So on one hand we have fMRI, on the other hand we have a diffusion tensor imaging. So when we were using this, for the clinical practice, all of us really wanted both the imaging to come on the navigation platform, but that's not the reality. It's very difficult to get them both because one is entirely functional with a totally different principle, and the DTI is another structural imaging. So what next? So then came in the tractometry, where the volume of the fibers could be studied, where we can look at various directions and see
whether they are involved in the networks. So, but then even that did not suffice when we were trying to look at the functional networks. So then came the principle of connectivity. So what if the cortical areas are connected, between each other, and through the fibers that we're able to see? So that took in another entirely a different level of advancement in the imaging. So that's when the Human Connectome project came in. All of you must have heard about Human Genome Project. Just similar to that, there's a Connectome project. So there were so many silent areas, there were so many cortical areas, and obviously the diffusion tensor imaging. So all the neuroscientists came together and they started out what is known as Human Connectome Project, which is around $38.5 million project with around 5 major centers, including Harvard University, and funded by the National Institute of Health, where they viewed a phenomenal, humongous amount of data, around 1,000 odd subjects, where they considered various task-related fMRIs or resting state fMRIs, and they pulled together the diffusion tensor imaging to study every single voxel of the brain to come out with an entire map of the within a nervous system. So that became the connectome. So connectome is obviously it's like a genome. Genome is a genetic architecture of the human DNA. Similarly, connectome becomes the neural architecture of the human brain. Basically, the entire circuitry of the brain, which area is connected to what area, what is its function, so that every single area is known now. To an extent, the Broadband's 47 became 180 areas. So I guess soon will be the days your neuroanatomy books are going to be in volumes, studying every single area because every single function has been laid out now. So this is the picture of cortical parcellations. You can even imagine how the Broadband 47 area has become 180 areas through this Human Connectome project. So how do we use this information in the clinical practice? That is the talk we are going to deal with today. So obviously we have fMRI, we have BTI. So the even for one individual patient, the data is huge. There's a huge data. So obviously we are looking at something known as big data analysis. So that's where the machine learning and artificial intelligence comes in and prepares the entire architecture of the circuitry, which is known as connectomics. So how do we really do it? What is the workflow involved? And it is nice to know it and even important to understand. Then you would appreciate what exactly is this connectomics. So as I was talking to you all about the functional MRI part, which is bold signal related, and then there is structural DTI component to it. So the functional area is basically all these nodes. So what are nodes basically? There's something known as graph theory, and graph theory is not just for neuroscience; it's networking, even in social platform, economic platform. It is a major mathematical model. So that is a model that they're going to use for they are using in the analysis of it, where the nodes are created using the functional MRIs, which are nothing but cortical parcellations, and then you have a structural DTI thing which acts as vertices or edges or links, which links the two nodes. Then the pipeline comes this way, where the parcellations are done, the extractions are done. Then each pixels are studied and see which two areas gave a signal simultaneously. So obviously those areas are connected. So you can see it in slides ahead that anatomically they are farther apart, but they are connected with functions. So that connections were done by the DTI. So this is the matrix I was talking to you all about. Once the nodes are created, once the parcellations are done, obviously we need to see which of those pixels are or voxels are connected. That is through the matrix analysis, where there is undirected matrix where only the signals comes up, but we don't know which direction the flow of information is happening. Similarly, if the same analogy is taken on the graph theory, you can see the weighted graphs or the directed graphs where the information is channeled in one particular direction. So obviously, directionality is a very important feature that we are trying to look here. So even for the patient that we use today, directionality was vital. So they have the algorithm saying that there should be more than 30 directions. So The directionality is very important because of this. The analysis happens with the directions. And it's all written in algorithm. We don't really have to physically sit and compute each other in each and every patient, but this is the principle involved. So once the nodes and connectivity is established, we need to quantify it. We need to see which connections are good or robust, and these are the various analysis that can be done. What is the strength of association between the two nodes? And you look at the weight of it, look at the centrality of it, and generate a module, like language module or a visual module. So you're basically looking at each and it's called hub. You look at a functional hub of speech, functional hub for motor function, or visual function, and then you see how each networks are interconnected. So obviously, when you see that, brain becomes a very complex weighted graphs. So the entire area is intertwined in each and every function. So how do we even break it apart to make sense of it? Obviously, then once we use the AI and algorithm, we could come up with a large scale networks of these many types. So I mean, these are the very vital functional networks which are known as of today. And these are the cortical parcellation for those networks, wherein you can see the multiple areas involved just for the visual network, somatomotor, and I'll come to those networks called default mode networks, which are higher cognitive networks, which are the benchmark of all these connectomic analysis. So obviously, when you look at the localizations view, compare that with what we have today, language is huge. I mean, look at the areas that are intertwined and connected. So there is something known as dorsal language pathways, where the entire pathway is dedicated for understanding the speech and do something with it. With the motor response, you respond to a person's gesture. So this is known as sound to motor pathway, where the Broca's area is connected. And there is another pathway which is ventrally located, where the semantic processing happens. You listen to them, you understand the meaning of it, and you can obviously you can appreciate that the larger amount of the brain network is used for that to understand what a person has been spoken to. Obviously, there is a big overlap with the auditory system as well. So, in a nutshell, basically we have dorsal and ventral pathways now, obviously with very distinct functions. So that's about the language network. So this is amazing because when we really want to operate on, for example, left-sided uh, motor area tumor, there's a glioma involved, we can use the connectomic mapping rather than depending on the fMRI. We really can't project that fMRI in the navigation, or we can't really use the detailed knowledge because it's all fiber bundles. We need something structural as well as functional to go ahead confidently and do what Dr. Theo did today. To recite confidently, we can get the entire connectome on the neural navigation platform and do the surgery as we just watched today. So similarly, we have the vital functional networks of visual networks and auditory networks. And of course, sensory motor. This is the beauty of it. What you're seeing here is all the cortical parcellation. Those small blobs, those are all cortical parcellation, which is until now was given by fMRI. And obviously the fiber bundles were until now was by the DTI. So with the connectome, all we have to do is to process that image and use it in a navigation platform where we can see the motor area along with its fiber bundle. So the brain mapping intraoperatively, where we have to depend on cortical stimulation, is far more easier when we have this knowledge shown on a navigation platform. So this is the major advancement. So and the next few slides will be on cognitive networks. So what we saw was all the basic functional networks. This is the cognitive network where the humans, they know that the difference between the human and animals makes, that is highlighted because of higher cognitive function. What we are, what we think, how we respond, how we even enjoy every single moment. So that is based on the cognitive networks. So one such network is default mode network, which is very important and connected with the medial prefrontal cortex, parietal cortex, and precuneus and posterior cingulate cortex. This take care of the functions of memory, In fact, it's not the memory that we really discussed with the temporal lobe and hippocampus. This is something of recall of the past, where multiple areas, multiple vital areas are involved, right from the occipital to frontal. So this is a network function. It's not a function which is limited to a particular area. So similarly, salience network, which maintains the saliency or the priority map of the visual environment, what we see. So that salience is maintained by this particular network with the larger role from the anterior cingulate cortex, supplementary motor area, and insular cortex. So central executive network, we discussed this again in the morning. The larger frontoparietal network, where this attention is sustained, where we can respond, and the task-based memory. As Dr. Dio was giving an example that a person sits in a car and he wants to drive, it's not just the visual thing that is required, but it's the entire guidance with this network that is what we require. So we are moving from the basic function to a higher cognitive function where we can take care of them. And it's not really very obvious. We operate on a patient, if there is a motor weakness, we can make out. But then when he gets back to his family, those are the functions which are lost, and then they'll get back saying he's not the same person. They may not be able to perceive it, but they'll say he's not the same. He's not able to, he's not really productive the way he was earlier. So those are the cases where these networks play a bigger role, much bigger role, where the cognition comes into picture. So another such networks are dorsal attention and ventral attention network, where there's something the attention in cognitive neuroscience has two approaches, where it's called top-down and bottom-up attention. So the top-down attention is basically with an internal cue, and you know what you're looking at, so your attention is diverted in that particular way, and the frontal eye feeds. So obviously, with the knowledge that you have about what you're looking at, you're able to sustain an attention. That is the top-down selective attention, the function of dorsal attention network. And then the ventral attention network, which is bottom-up, where you scale each and every thing that you're looking at. So obviously, the temporoparietal junction is which plays a very vital role for this particular attention, which is based entirely on the external cues. You know, so with that I'll be ending my talk. Thank you all for the attention.
Thank you, Dr. Shabri. That was a wonderful explanation of the basics of DTI, functional imaging, and how we've evolved into connectomics over the last 10 years or so. Any questions from the students here or the other faculty? And next up, we have Dr. Rakshit, who is a neurosurgeon who is going to be speaking about the widespread applications of connectomics in neurosciences.
Good afternoon to everyone here in the audience. Dr. Shabri has made my job very easy because he has covered most of the topics which I would have to cover. So I would be talking about the applications of connectomes in neurosurgery. So basically, connectomes is a word that has been derived from omics, from genomics. It's a combination of connections and genomics. Connectome basically uses big data, that is data from multiple sources. Basically, it is an MRI-based data, but also EEG-based data have also been used in some places. And these data undergo various processing before we form what is a connectomics. So connectomics is a study of connectomes. What are connectomes? Connectomes are comprehensive maps of network connections in the organism's nervous system. It is basically a study of neuronal wiring diagrams, which Dr. Shabri has shown that it focuses on both structural connectivity as well as functional connectivity. So it basically uses a functional MRI and a diffusion tensor MRI to show the structural connectivity in the brain. It was first described by Dr. Olive Spons and Dr. Patrick Hagman in 2005. Dr. Spawn was actively involved in the Human Connectome project, which Dr. Shabri spoke about, and they emphasize on the importance of this network in cognitive neuroscience and neuropsychology. Dr. Hagman in 2005 said that Connectomics has been defined as the science concerned with assembling and analyzing connectome data sets. So what it basically uses is a diffusion tractography and functional MRI. So basically each human brain MRI is taken and formed into an average brain template using sophisticated computer algorithms. The template, each template consists of fine voxels which have distinct address, which allows comparison across subjects with varied brain morphology, also referred to as normative spaces. Subsequently, the voxel-based group statistics, functional and structural connectomics, and imaging transcriptomics analysis is performed. So all we basically require is a simple MRI brain, and in some centers, if we have the facility to do a diffusion tractography or a functional MRI, and with the help of the computer, the special computer programs, that the two programs are wrapped on each other, and you get the final networks. So the brain connectome can be assessed using different MRI acquisitions. Dr. Shabri has dealt with that, both diffusion weighted MRI, which gives the tractography, and the resting state functional MRIs. Now, tractography has also gone through various stages of advancement. So initially, tractography, you can see on the left side, this is, sorry. The A is a simple tractography model, whereas once you come on to the B, the next model, they found that these tractography images had issues related to brain edema, which is commonly seen in brain tumors. So the advancement or higher definition tractographic images were used in the formation of the connectomes. Now, there's a Dr. Shabri also spoke about something called parcellation. Parcellation is basically the data collected with the big data was too much of information. And what we needed to do was divide these informations into anatomical subunits, which was meaningful. The human cortex is divided into meaningful anatomic units, which was called, for example, is the Broadband area, which showed the psycho-architecture of the, which was used in the Human Connectome project. Reparcellation was a method wherein the big data was used with the help of machine learning and artificial intelligence. So this helped us in not only superimposing or wrapping the data available from various defined human atlases, but also forming a patient-specific MRI or connectomes. So this is the basic methodology where the patient's MRI, with this is the tumor, is taken, and the patient's MRI is segmented, and once the segmentation is done, they use Montreal Neurological Institute templates. These templates are wrapped onto the patient's MRI, and once that is done, they can be used for either the DTI imaging or the fMRI imaging, and that results in an advanced neuroimaging as a final output of this process. Similarly, the voxel analysis is done to to study a particular lesion in a particular area. The functional MRI voxel is used
to identify the function of the brain around that particular area, and the diffusion tensor imaging work cell is used to show the tracks that follow along the particular area of interest. And then once all these images are taken, they are integrated with the genomic transcriptomics. And the advancement in this stage could also predict a particular tumor in a particular area, what genes could be predisposing to that tumor. So going to the applications, this connectomes, what we used to do in patients with tumors, we would basically look if the tumor was on the left side or on the right side. Mostly we would consider the left side as an eloquent area where the speech areas and the motor functions, and on the right side the motor areas as an eloquent areas. But now with advancement in MRI technology and connectomics, we have realized that those areas which were considered as non-eloquent actually have a lot of networks which make that part of the brain eloquent. So in the earlier days, all we used to do is a functional MRI, and probably we would use an intraoperative monitoring to stimulate the white matter tracts as we are removing the tumors. But post-operatively, we would be quite surprised, in spite of using all the available techniques, the patient has deficits that we could not explain. So to circumvent this, the connectomic or the network theory helps us to prevent these kinds of deficits in our patients, like what we have seen today. So the next generation tractography basically is going to help us to achieve what we call as an oncofunctional optimization, which is a connectome-based resection. So it is going to define our resection of tumors based on the networks. So that's what we call as an oncological disconnection surgery. So Dufoy is one of the leading neurosurgeons who perform awake craniotomies. He's a French neurosurgeon, and he says that neurosurgery is no more a focal surgery but a brain network surgery, which seems to be very true after we gain knowledge with the connectomes. So this is an example of a tumor with various nodes and edges, which Dr. Shabri explained. So when we take a decision of the initial incision, the corticectomy, and tumor excision as we go towards from the gray matter to the white matter, we need to keep in mind these networks. So the connectomics has an application in traumatic brain injuries as well, by using advanced imaging techniques like functional MRI, EEG, and transmagnetic EEG, which is neuronavigation based. FTG PETs, connectomes are formed, and it has been shown that the residual structural functional connectivity of long-range cortico-cortical neurons connecting the prefrontal and parieto-temporal and the cingulate cortices, which is hypothesized as a major determinant for recovery of consciousness after traumatic brain injury. So this is going to help us prognosticate a patient post-head injury. So the tracks that are most vulnerable to head injury includes the long coursing, that is the DMN node, and the commissural fibers. Midline structures such as corpus callosum may be more susceptible to rotational and shearing forces other than the brain injuries, what we commonly see in diffuse axonal injuries. So a study done by Nakamura et al., he used the graph theory, have demonstrated a reduction in what is called as small world properties in traumatic brain injuries, which resulted in decreased network efficiency. So connectomics is also used in deep brain stimulations for Parkinson's disease, dystonia, and essential tremors. See on the right side, you can see the VIM nucleus, which is commonly stimulated for the essential tremors. With the use of connectomics, we are able to find the fiber tracks from the left dentatorubro-thalamic tract. and various studies have noticed the better response after stimulation of these dentatorubro-thalamic tracts, better control in tremors. Similarly, this is a 7 Tesla MRI with diffuse traction, DTI images showing the tracts along the subthalamic nucleus, which is utilized in the stimulation for Parkinson's disease. So Connectomics is used in psychiatric disorders like OCDs. Um, there's an entity called a dorsal anterior cingulate cortex, which detects a conflict between affective evaluation. That is, affective evaluation is a limbic loop which is related to disgust and anxiety, and a cognitive loop which is related to working memory and long-term goals. So active DBS or active identification of this network and inhibition of these pathways can help treat OCDs. Um, Connectomics in epilepsy surgery. So it has been found that there is a widespread structural and functional abnormalities is observed in mesial temporal lobe epilepsies. Mesial temporal lobe epilepsies may be better characterized as a network disorder. Brain network organization may be predictive factor for the outcome. So functional connectivity studies found abnormal topological organization in temporal lobe epilepsies, suggesting the brain connectome is an effective way for understanding the functional alterations. Consequentially, assessing the global disturbances of brain function rather than evaluating planned resection areas in isolation. So understanding this network in epilepsy surgery is very important before we go ahead with a simple amygdalo-hippocampectomy surgeries. So connectomics can also be used in various neurodegenerative disorders like Alzheimer's and multiple sclerosis, which Professor Theo will be talking to us in detail. Thank you.
Thank you, Dr. Raksha, for that introduction to the widespread uses of connectomics in neurosciences. I think with Dr. Shabari's explanation and Dr. Rakshit's little talk, we've understood how we go from imaging, both structural and functional, combining them to form connectomes and maps of brain. Now Dr. Theo will enthrall us all with his talk on oncofunctional preservation, and he calls it golden fleece.
Thank you very much. Thank you very much for that introduction and the background information on Connectomics. Dean and Vice Dean, it's lovely to see you here, and thank you very much for coming to listen. My introduction is pretty simple, really, and that is that I'm pretty old now. I've been in neurosurgery for 37 years, and I've done 11,000 brain tumours. And I must say that as I was getting close to the end of my career, I thought that I would never change my approach to brain tumours or brain surgery. But then a guy called Mike Shagru, he's a neurosurgeon who was my fellow back in 2010. He came back to join me from America after he'd been spending about 8 years of his life studying connectomics, and introduced me to the whole subject. Well, initially I felt that I didn't quite have the mental capacity to relearn the anatomy of the brain and then incorporate that knowledge into my practice, so I ignored it. And unfortunately, it became pretty clear that I couldn't ignore it anymore. In fact, the knowledge of connectomics explains many of the bad outcomes that I've experienced over my career. Some of the surprises after surgery where I thought things went very well but actually didn't. And so I'd like to share those mistakes that I made with you in the hope that the next generation of neurosurgeons won't make the same mistakes as I made. Furthermore, you've also heard about what's that talking? You've also heard from the other speakers that is that me talking?
I think you're going online.
Huh? You're live on YouTube. Oh, can you turn the volume down a little bit on that? Oh, thank you. You've heard the other speakers that this whole knowledge of connectomics doesn't just apply to neurosurgery. It can be applied to many other disciplines that deal with the brain. So this is going to be an introduction to how I've applied connectomics to my practice, how I believe that it's really improved the outcomes of my patients, and then how we've taken that knowledge and expanded the applications to other neurological problems. So neurosurgeons have been typically pretty primitive and a little bit backward in the way we examine our patients. Our neurologist colleagues have always identified that as a problem, but we have always felt that the measure of a successful outcome is a patient who's not paralyzed and who can talk. Our skull-based colleagues have been a little bit more sophisticated than that, and over the years they've developed different metrics or different yardsticks for a successful outcome. For example, acoustic neurosurgery, back when Cushing first wrote the paper on acoustic neurosurgery, talked about success being an alive patient versus a dead patient. And then in the 1960s, 70s, 80s, we felt a good outcome was a patient who didn't have a brainstem infarct. And then in the 1990s, we became so sophisticated and that we measured success by whether we could save the facial nerve or not. More recently, however, we've attained a level much higher than that, where now the metric or the yardstick for a good outcome is hearing preservation or not. The glioma surgeon hasn't quite got to that level of sophistication. And I must say that most glioma surgeons use as a metric whether the patient is paralyzed or not and whether the patient can speak or not. And if they can speak and move, that is considered a good outcome. There's a particular type of tumor called an insular glioma, which is quite complex. And in fact, many people don't operate on insular gliomas because they are in a very delicate part of the brain. And my confession here is that I am one of those surgeons who have always used a very rudimentary neurological examination as my assessment of the success of one of these operations. So I go around the world giving these talks about how good a surgeon I am. I show a preoperative MRI scan and a postoperative MRI scan showing the tumor's gone. And then I show the patient with their thumbs up, as you can see in these pictures, smiling, thanking me for the operation, and that then is meant to indicate to the audience that Dr. Teo has done a great job. But here's the problem. It's a bit dark, actually. Yeah. Can you brighten that up a little bit? Yeah, I can brighten. Can you increase the brightness? What? Yeah, doesn't matter. Doesn't matter. Oh yeah, there we go. very much. Thank you. Yes, but here's the problem. The problem is that every one of those patients who looks superficially very good, not paralyzed, smiling and talking, in fact filled out a questionnaire after surgery that said that their quality of life was worse. So again, if you did a very rudimentary sort of assessment of them, you would say it was a successful operation. But in fact, the patients themselves felt they were worse after surgery. So since I was made aware of Connectomics, I've done a much deeper dive, a much more detailed neurological examination of my patients after surgery. And disturbingly, I have discovered that they're not as good as I would like to think. For example, 90% of patients diagnosed with a brain tumor will suffer from major depressive disorder after surgery. Now you are probably sitting there like me and say, well, you know, you've been just told you've got a brain tumor, of course you're going to be depressed. It turns out that patients with cancer of the pancreas, just as deadly, only have about a 40% incidence of depression. So clearly something we are doing to the brain makes these patients depressed. 90% of patients with an insular glioma are unable to enjoy sex after surgery. Okay. Why didn't we know this? Because very few of us ask a sexual history of our patients after surgery. And these patients cannot enjoy an orgasm like they could before surgery. 90% of patients, 90% of partners say that their patient is not the same person. And I think you heard one of the previous speakers say that, and it's true. That sometimes they come in and they can't quite pinpoint what's wrong with the patient. They can't put their finger on it, but they say, doctor, it's just not the same. Not returning to work, not interacting as well as he used to. He's not the same person. Now, granted, a few patients are better people after surgery, but most of them are not quite the same in a bad way. 70% of patients after surgery for a hemispheric glioma do not return to their previous level of functioning. So, yes, they might go back to work, but they will never achieve the same level of functionality as they did before surgery. And yes, they might be students who do reasonably well at school, but they won't attain the same levels. So there is absolutely no doubt that brain surgery has a huge psychosocial, cognitive, lifestyle and emotional impact on our patients, despite the fact that these patients don't have overt neurological problems. I use this as a perfect example of what I'm trying to say. So again, this, for you students who don't know what it is, it's an insular glioma. It's part of the brain that is buried underneath this more sophisticated cortex. It's very old in its anthropology, and in fact, it has very old sort of function as well. Good resection, a good-looking patient. Another insular glioma, good resection, a good-looking patient. But here's the problem. Those pictures were the sort of pictures I would use normally, or previously, to demonstrate that I had a great outcome after removing those tumours. But if you listen to the interview of these ladies, the one on the left is normal, and the one on the right is anything but normal. Hang on, I just have to change the setting here so that you can hear it. I'm just going to go to this. I'm going to go to headphones. This should do the trick. Today? Today I went shopping. Good. And went. Okay, Jane, if you could just say something to us to show that your speech is normal. Tell me what you did today. Today I went shopping. Good. And came in. but normal. She's lost her empathy. She's emotionally labile. She's angry. She's so angry, in fact, that the husband had to take time off work to look after the children. She threw her own mother-in-law and her mother out of the house simply because they wanted to come and help her with their housework. So yes, on a superficial picture, she looks good, but when you do a more detailed assessment of it after surgery, she is nothing but good. Why does it happen? Well, neurosurgeons have been very quick to blame everything else. We used to blame the air hitting the brain, and in fact, this was not so long ago. When I was a lad, first starting neurosurgery, if the patient would wake up in a sort of bad, sort of emotional, psychosocial way, my boss would say, "Oh, that always happens when the brain gets when the air hits the brain." So that was something that we used to think about all the time, and then of course after that we blamed other things like the emotional impact. We blamed everyone else. We blamed the anaesthetist, the oncologist, the radiation, the steroids, and me. I used to blame brain smoke. So what I used to do was say, look, sure, they might not look 100%, but don't worry, it's going to get better. It's just a bit of brain swelling. Trouble is, oftentimes they didn't get better. So we're very quick to deflect the blame, but in fact we should accept some of the blame. Why? Because there is absolutely no doubt that the surgeon does damage brain. We damage it intentionally when we make trajectories into deep-seated tumours, and we damage it unintentionally when we go beyond the interface and we cause infarction and vascular damage. But this is what I used to say. I used to say it didn't matter about damaging that brain because it was non-eloquent. It served very little purpose, or any deficit that you got from it was barely discernible. And so we talked about this whole concept of being allowed to damage brain because you're going through non-eloquent brain. I think before 2016 it was reasonable to adopt that approach. The trouble is, in 2016 we were informed of the results of the Human Connectome project, which you have been beautifully educated on by the two previous speakers. And so in 2016 and beyond, I don't think it is reasonable to think of this concept of non-eloquent brain. I think now all brains should be considered eloquent. Sure, some may be a little bit more eloquent than others, but nevertheless eloquent. So you've been told very nicely what these brain networks are. They're nodes that wire together, they fire together, they serve a common purpose, but they mix parts to create this high cognitive function. What is a high cognitive function? Very simply, it is what differentiates a human from an animal. So an animal, it's a sentient being, they have emotion, they have motor function, vision, their own language. But if you look at what humans have beyond that, it's a much more complex, higher cognitive level of performance. Things like imagination, hope, a theory of mind, empathy, pleasure, all these higher cognitive functions are what we're talking about when we're talking about these functions of the networks. They lie in a hierarchy, and I think the analogy, this is a really good analogy, it's like an orchestra. The music that comes out of an orchestra is beautiful. And when it's beautiful, it's kind of like a function. So that, let's pretend it's imagination. Well, imagination is not determined by just one network, like the music is not determined by one section of the orchestra. It is determined by all the sections or all the networks working in perfect synchronization, and that's what a function is versus a network. How do we come across it? Well, again, you've heard very nicely from the others. Why did it take so long? Well, it took so long simply because it's a huge amount of data that needs a huge amount of processing, and we never quite had the computer capacity to do it until now. The Human Connectome project, as described to you, was about a $40 million project. 1,200 subjects. They were investigated to the hilt, even genomics, transcriptomics, MRI, functional and structural. A whole lot of data was generated from these 1,200 people. And then this allowed us to then come up with the HCP, which was still distilled into this article by Glasser and al. in 2016. The 7 major networks, again, you've been exposed to them. In summary, I'm just going to tell you how I remember them. I sort of give them nicknames. So the salience network is probably the kingpin sitting at the top of the higher order networks. I call it the conductor of the orchestra because, in fact, it's very, very instrumental in determining the relationship between the other networks. CN, I call that the on network because it's turned on when you're doing things, and DMN is the off network because it's active when you're not doing something. Sitting there, listening to this conversation, using your imagination, going to sleep, that's DMN. I'll give you one example of how delicate this balance is. When CEN is upregulated, DMN is downregulated, and vice versa. It's salience that controls that sort of circle. If you have a situation where salience is broken or dysfunctional, and CEN and DMN are upregulated simultaneously, that's schizophrenia. So just a small problem in one of the networks can result in a huge behavioural problem in a patient with a significant effect on their quality of life. Again, we've been through this, so if you don't mind, I'm just going to skip it. But you heard about the DMN, the CN, the salience network, DAN, BAN, language, incredibly complex, sensorimotor, limbic, and of course, so now let's put it all together. When my forefathers taught me to do a right frontal lobectomy for a tumour, they taught me that it's perfectly okay because it's non-eloquent brain. From 2016 onwards, we now know that that non-eloquent brain, i.e. the right frontal pole, not just the right frontal lobe, but that 3 or 4 centimetres of the right frontal pole includes parcels that are part of every one of these incredibly important networks. So when we do a right frontal lobectomy, we can potentially cause damage to so many structures that all these symptoms can be unfortunately experienced after damaging the right frontal lobe. Now, I would contend that if I went back and did a more comprehensive evaluation of all my patients who had a right frontal lobectomy, I bet you that if I asked the appropriate questions, i.e. things like, how's your imagination, tell me about your theory of mind, I bet you that I would find that most of them, if not all of them, had some problem with those functions. But we never asked. We just made sure they weren't hemiplegic and weren't dysphasic. We are therefore pretty good at monitoring, mapping, and preserving the lower order networks, things like motor, sensory, language, and vision. But we're not good at monitoring, mapping, and preserving the higher order networks. Currently, we use preoperative maps, but I think you've seen very nicely from Shabri's lecture that, in fact, even preoperative maps currently are not that accurate. They're mostly based on DTI, inaccurate. Most of the maps of the cortical surface or the grey matter is probabilistic. In other words, it's not really the patient's map, it's what they presume should be on the patient's scan. In other words, what they do is they take an HCP atlas, they overlay it over the patient's MRI and go, there you go, that's that patient's speech area. They shouldn't be saying that. What they should be saying is that's not the speech area, that's where the speech area ought to be, or we think that's where the speech area is. It's not the patient's speech area, it is not patient specific. Functional maps, well, they're mostly task-based, so they really only test the task that was asked of the patient during the MRI. Intraoperative sleep mapping, well, of course, you can't map many complex motor functions or language functions when the patient's asleep. And intraoperative awake mapping, well, it has its major limitations as well. It's probably the gold standard of mapping and monitoring, but again, it has limitations. So, what about high order networks? Preoperative maps, waste of time. Intraoperative sleep mapping, you can't map someone's imagination while they're asleep, and awake mapping. So let's talk about awake mapping. Defoe is the absolute doyen of awake mapping. The guy is a genius. He has produced so much literature and taught us so much about awake mapping that it's crazy. He goes around and says that you can map all the functions of the brain, including the higher cognitive functions. The trouble is, I believe him. He can, but the trouble is most people can't. And most people who do awake surgery find it very difficult to assess those high cognitive functions. In fact, even Defoe's neurologist, who is the co-author on most of his papers, has come out more recently as his own author, without Defoe, saying in fact that he doesn't think you can map, monitor and preserve higher cognitive functions. He says it's just too simplistic, it's too reductionist. These are very, very complex pathways, and a simple little stimulation in the operating room is not going to assess properly these higher complex functions of the brain. So what we're saying is that with brain surgery, it is important to take out a tumour, and in fact, most studies have shown that patients survive longer if you take away a little bit of normal brain as well. We also know that you can't hurt patients. Any survival advantage of a gross total resection is negated by a patient who is hurt by surgery, either overtly or covertly. So we really are in desperate need of accurate, patient-specific, comprehensive maps. And what I mean by that, not maps just of motor and speech, but maps of CN, salience, demon, and all the other higher cognitive networks. So this is where I'd like to introduce you to what Mike Shagru gave me 2.5 years ago. So I'm a consultant for the company. You've got to, unfortunately, take everything I say with a grain of salt. But I will tell you, hand on heart, with all honesty, I will not do a brain tumour anymore without this information. Once seen, it cannot be unseen. Once you know about these networks and you know the damage that can be caused by damaging these networks, you must, to be responsible to your patient, incorporate it in your decision making. What did Mike Shagru and the scientists provide us with? They provided us with a software package called QuickTime. It provides a personalized, so it is patient specific, okay? It's not just a probabilistic map, it is a deterministic map, patient specific, of all the networks, not just motor, sensory and vision and language, but all of them, and it's incredibly accurate. Why is it accurate? Because it corrects for space occupying lesions, it corrects for edema, it's incredibly user friendly, it can be used either in your office to consent patients, to plan the surgery. It can be taken down to and married with your frameless guidance system to pick trajectories and make surgery more accurate and safer. And it's now FDA approved and Indian approved as well. The specs are very non-onerous. Again, it's just DWI pictures or sequence with about 30 directions minimum. The more the better. That means the processing time is the same. Sorry, the acquisition time is the same. It's about 30-minute scan that any scanner can do as long as it's not older than about 10 years old, the MRI scan. It corrects for noise and edema, and this is how the genius of this company did it. So a lot of people say to me, well, how is it that Omniscient has created a personalized map of the brain? And you have to go back a couple of steps. And I'm going to dumb it down for you because I'm not as smart as the two previous speakers. I didn't quite understand the concept of physics and fractionality and stuff. So what I'm going to do is I'm going to dumb it down for you. DTI is a processing method of taking the DWI images and creating maps of the tracks, the white matter tracks. It uses a principle that if you pick a particular voxel, which is a three-dimensional volumetric spot,
it will pick up the major fiber tracts running through that voxel. So the major white matter tracts running through that voxel are picked up and the minor tracts are eliminated. So that's why you get a very, very detailed and accurate map of just that fiber tract. The trouble is that if, for example, in that voxel, there are two major fiber tracts, one occupying 49%, the other one 51%, it will eliminate the 49% one. And that's how you get these inherent inaccuracies in DTI processing. If you take those DWI images and process them with CSD, constrained spherical deconvolution, you will acknowledge and pick up every fiber that's running through that particular voxel. So it will pick up U fibers, for example, kissing fibers, fanning fibers, all those other fibers that are important in terms of connections will be picked up with CSD processing. That, as you heard, has to go through a lot of machine learning because it's a huge amount of data, and then they repassate. And I think you heard what repassation is. Again, just to dumb it down for you, because I needed them to dumb it down for me, this is the analogy. If that was a picture of the world from space, and your partner in space says to you, I want you to tell me where Dubai is. So there's one way of telling where Dubai is. If you get an atlas and overlay it over the picture, that's parcellating it, parcellation, that's one way of telling where Dubai is. Now there's another way of telling where Dubai is. Just imagine if you knew all the flight paths that go through Dubai. So you know that the flight that goes from Sydney to London has to stop at Dubai. So if you had a map of the flight path, wherever that plane stopped is Dubai. Now, if you had all the flight paths going through Dubai, then I think you can understand that Dubai would have a Dubai would have a very typical pattern or a typical signature, because flights that go from Johannesburg to Moscow have to go through Dubai. Flights that go from Washington to wherever has to go through Dubai. So you're starting to now pick up very specific information about Dubai. So that means when Dubai moves from an earthquake, if you just put your atlas over the top of that, it's going to tell you that Dubai is here. If you knew the flight paths where the plane stopped, then it's going to tell you where Dubai is. Not where it was, or not where it should be, but where it is. And that's how these geniuses have come up with a patient-specific, personalized map of your brain based on that incredibly comprehensive map of white matter tracts that you saw that we got through CSD, constrained spherical deconvolution. So take that analogy to the brain. Take that analogy to the brain, and let's talk about a network like language, for example. We know that language has all these different parcels, 44, 45, 8AB, PIPL, etc., etc. We know from all that literature that the two previous speakers spoke to you about, that there are very, very specific number of fibers that run between 45 and 44, 800 fibers. We know that there are 600 fibers that run between 55B and 44. So 44 has this incredibly specific signature, so that if 44 were to move because of edema or because of a brain tumor, we'll know exactly where it is. Once that map is then constructed, the images are sent back to the surgeon or the doctor, and that image comes back as a DICOM file, which then all you need is Google Chrome, and you can use those images for whatever reason you like, again, to just examine them, talk about them, consent your patient properly, or use it in the operating room. So I want to show you a couple of examples of how I didn't use QuickTone, and then I'll show you some examples of where I did use QuickTone, and I think you'll see the outcomes are pretty dramatic. So this was a 36-year-old lady who presented to me about 15 years ago. She was an incredibly capable woman with great social skills, good communication skills, good organisational skills. Okay, she had this tumour, this here. It had been biopsied by someone else, came back as a low-grade glioma. She came and saw me and said, "What would you do?" I go, "Well, look, these low-grade gliomas can turn into high-grade gliomas. If it does that, you're going to die. There's a chance that if I do a nice radical resection of that, it could cure you potentially, and it certainly would buy you some time. Furthermore, because it's in the right frontal pole, I said to her, let me do a radical supramarginal resection, and that will improve the odds of you not dying from this even more." She goes, "What? You're going to take away some normal brain?" I go, yeah, no, don't worry, it's non-eloquent. And again, I was justified in saying that because I was taught. And 15 years ago, we didn't have the HCP anyway. So I told her and reassured her that this was non-eloquent brain that I could take out with impunity and not cause any problems. Okay, Dr. Teo, go ahead. So we did the operation, nice incision. You can see I took some normal brain as well as the tumour, and the post-op scan looked terrific. So, tumour all gone, no residual tumour anywhere, and 15 years later, she's cured essentially. No recurrence and no malignant transformation, no further surgery, no other treatment, no radiation, no chemotherapy. But here's the problem. The problem is, from the day she woke up from surgery, she has not been the same person. She would tell me time and time again, as soon as I woke up from that operation, I was depressed, I had anxiety, I had lost all my working memory, I had no organisational skills, I couldn't multitask anymore, and she put it down to the surgery. Now, if you read between the lines here, you can see that I'm a little bit annoyed by her. Because every time she told me she was worse after surgery, through my ignorance, I would say to her, it's not my surgery. Operating on the right frontal pole, non-eloquent brain can't cause memory disturbance. It can't cause depression. It can't cause anxiety. And I would keep telling her that her problems had nothing to do with surgery, and she would keep telling me that it happened straight after surgery. And again, I'm not going to show you every clinic note, but every clinic note she told me she had problems. And at the end of the day, this is what she had. She had no working memory. She had a total change in her personality. She was depressed. She had anxiety. She couldn't multitask anymore. In other words, both these networks were destroyed by my surgery. And again, I don't blame myself. I wasn't arrogant about it. I was ignorant about it. I had no idea that the right frontal pole had these higher cognitive networks in them that can cause those sort of problems. Here's another case, and this case is, again, a little bit of ignorance, a little bit of arrogance. This is a GBM. This lady presented about 4 years ago. Mike Shagru had joined me at that time. It was a GBM, someone else had biopsied it. She came and saw me. I said, yeah, I can take that out for you. You shouldn't get any paralysis. There's the motor area, well away from the tumour, so we took it out, and she did very well, no paralysis. She came back 14 months later with this, and this is now another tumour, the right brain as opposed to the left brain over there, and it looks like it's probably multifocal GBM. Well, it's in the right frontal lobe, and again, this time Mike had only been with me for a few weeks. I didn't really know much about the networks, and every time he told me, I just didn't understand it anyway. So I said, listen, I think I'm just going to do a right frontal lobectomy. Mike goes, can we map her with my new software? I said, fine. So we mapped her, and we found out that she in fact had parcels of central executive network in the tumour. I felt that I could still take it out without any sort of mapping or without any of my software, and I did. I took it out, and you can see I did a very radical resection,
looks good, and of course she was good because I saved her motor function, and that was one day after surgery saying, thank you, Dr. Teo, and went home, day one. Of course, I was pretty proud of myself. You know, I said to Mike, see, that's what experience does. That's how good the patient can do. But the trouble was, 6 weeks later, she came back with this picture. You can see that this is a preoperative central executive network, and the postoperative central executive network represented on this 3D image with lots of fibers going between different groups, parcels, and after surgery, all those fibers are destroyed, and some of the parcels are destroyed. At 6 weeks, her husband wrote a note to the patient, his wife's sister, saying, if you're going to look after her, you've got to watch out for these things. I've got a copy of that note, and I'll never forget it because basically it is a textbook example of central executive network being ruined. So remember what I told you, these patients can walk and talk, they can smile, but they can't do higher cognitive complex things, such as they can get in a car, they can't drive it. They can go to a restaurant and order food, they can't eat it themselves. They can pick out their clothes, they can't wear them. They can't dress themselves. So this is my point to you. My point to you is this, that would you rather have a mild hemiparesis or would you rather have that? I'm telling you which I'd rather have. I'd rather have a hemiparesis or a speech problem than lose my independence with a loss of my central executive network. So please don't think that these higher order networks, when damaged, can be tolerated by the patient. They can't be. In fact, I think that damage to the higher order networks has much more negative consequence on quality of life than a mild hemiparesis, a speech problem, or a visual problem. So thankfully, I learned my lesson, and you can see that in this case, I think it's the oncofunctional golden fleece because we get good oncological outcome and a good functional outcome. So this is a right frontal tumor. Before surgery, you can see that we are planning the resection. I think posteriorly and medially it's pretty simple, but anteriorly it wasn't quite clear to me whether I should resect there or resect there. Superiorly, the same sort of thing. Inferiorly, medially, easy to assess, but superiorly, do I resect there, there, or there? Now, pre-QuickTime, I can tell you now with 100% honesty, if it wasn't for QuickTime, I would have done that resection. I would have done maybe even more. I might have done a supramarginal resection to try and buy that person time. But the QuickTime scan shows, in fact, that that questionable area contains parcels. This is sensory motor. Showing that most of the parcels of sensory motor are clear of the tumour, except for this one right here. That parcel there is probably, or that one there, it's probably face. So I warned the patient that, you know, unfortunately the face part of your brain is very close to this tumour. The central executive network is well away from the tumour, so I could reassure him that there won't be any problems with the CEN. But unfortunately, the VAN, the ventral attention network, has parcels in that questionable area. Look there, look there, very closely right there, and you'll see that those parcels are in that area that we didn't quite know we should resect or not. So then I can say to him, with that information, look, this is going to be a relatively safe operation. Chance of being paralysed are less than 5%. Chances of a facial weakness is less than about 15–20%. But the trouble is, if I'm aggressive with this tumour, then the chances of getting a VAN problem, a ventral attention network problem, is around 50–80%. What does that mean, doctor? It means that, you know, you're going to have problems with switching thoughts, being versatile in your thinking and your actions, having some visuospatial problems. He goes, hang on. I'm 44, I really enjoy life, I'm very active, I'm a competitive BMX rider. And so he goes, I don't want to have the risk of losing those functions. And that to me is a major advantage of having this information at your fingertips, because you can then give your patient much more comprehensive informed consent and let them decide the risk they're willing to take. He didn't want to take the risk, so I knew that I had to try and preserve those parcels, and that's exactly what we did with surgery. We'll see pre-op and post-op. I preserved that area there. It turned out that that area there was in fact normal edematous brain, and you'll see how accurate QuickTome is, because after the operation, when we did a QuickTome scan, you can see those parcels in that knob of tissue that I left behind. In keeping with the fact that I preserved all the parcels, after surgery, he was completely normal. So that's him saying that I've just competed in a BMX competition 2 weeks after surgery, that I used to have a weak face after surgery, but now it's better, and I'm 100% completely normal. So from a neurosurgical viewpoint, I think we can make some conclusions that we no longer should measure our patients' success by just that rudimentary assessment of the lower order networks. I think now it would be irresponsible to say that a patient has a good outcome just because they can walk and talk. I think now we need to measure our patients a little bit better than that by not only doing our neurological examination, not only doing neuropsych batteries, but asking the person who knows best, the loved one, the father, the mother, the partner, is he normal? If he's not normal, what's wrong? And I think you'll get a clearer indication then of outcomes after surgery. Now I'd like to talk a little bit about the future, and I think you'll find this pretty exciting. And that is, we've taken this information on Connectomics, we've taken QuickTome, and we've added resting state information. In other words, functional information to that. If you think back at what I've just said, I've just shown you these amazing maps showing these blobs of color, and I'm telling you that those blobs of color are part of networks. What I didn't tell you is how essential those blobs were. I didn't tell you how important they were to someone's overall function. So it's quite conceivable that even though there's a blob there, you could go through that blob, damage it, and not have any consequence. Now, I know I'd rather not do that, but nevertheless, until we know how essential those blobs are, until we know how functional they are, then we don't know if we can damage them or not. So here's what QuickTome is going to morph into, and this is what Omniscient is doing with the next phase of their R&D. So again, I'm going to show you an analogy. That's an MRI scan on the right and a map of Sydney on the left. What is DTI? DTI is kind of like those old-fashioned printed street maps that we used to use. They were reasonably accurate, showing you the major highways. They were only updated every 5 years or so, so they really didn't show you the recent advances in buildings, laneways, etc., etc. And that's what DTI is. It's pretty inaccurate, but it's not too bad, showing you some major highways. Many of the companies then add the HCP atlas to that, non-patient specific, and that's what that looks like, where you see parcels within the tumour that really shouldn't be there because they probably aren't there. QuickTome, the structural connectivity atlas, is basically that. And what that means is that it's a much more comprehensive and detailed and accurate white matter fiber tractography, and the parcels are where they are in the patient, in other words, personalized parcelization of that person's brain. It's not dissimilar to a Google map. Google Maps, sure, it's not live, it's not real time, but it is updated much more frequently than the printed directories. It does show you the recent advances and renovations. It shows you the trees, the buildings, the laneways. It even shows you the boats in the harbour. So it's pretty good, even though it's not real time. Now, wouldn't it be good if you had a real time map? do. Google Live is a real-time app. It's showing the traffic on the highways. In other words, it's showing you the traffic or activity of the roads. It will also show you if people are going in and out of buildings. In other words, if those buildings are empty or those parcellations can be destroyed and not cause any functional outcome. And that is what QuickTone Bold is all about. QuickTone Bold is now basically taking the structural connectivity atlas and adding to it live information about the functionality of that of those parcels and those highways. In graphic detail, it's showing you in the graphic form of this is a matrix that it produces, and the matrix basically shows how one part of the brain talks to another part of the brain. If it's white or black, it's basically normal functioning. If it's red, it's over-functioning or over-talking. And if it's blue, it's under-functioning. How do we know what normal is? Well, it turns out that Omniscient has been accumulating the scans of normal people for the last 3 years. It now has the largest repository of MRI scans on normal people. On all these people have had neuropsych and interviews and consultations so that they are normal, and we can then compare the patient's activity or functionality to the normal and tell you if it's over talking or under talking. Well, what can we do with that? Well, this is what's really exciting. Now that we actually know what's going on in the brain, we can now start modifying those networks. Now, it's not as if we're the first to do that. Our psychiatrist colleagues have been modifying networks for 3 decades now. They've been using a thing called TMS, and they've been hitting the dorsolateral prefrontal cortex and actually treating about 40% of patients effectively with depression. TMS stands for transcranial magnetic stimulation. It works on the principle that a magnetic field can alter the magnetic fields in the brain, the electrical currents in the brain, and kind of reset the brain to a default setting, which allows it to then behave in a more normal pattern. The trouble is they've been giving that TMS in a non-targeted fashion because they've never had a map. And I think that's the reason why it works in some people, but doesn't work in everyone. It's kind of like getting a shotgun and shooting in the dark. You will hit the target occasionally, you're just not going to hit the target every time. Well, our neurologist colleagues have taken that principle of TMS modifying brain networks and started treating patients with neurological problems. If you look at this, there are 34 studies on stroke, TMS for stroke. And if you look at the literature, does it improve function? Absolutely it does. All those 34 published trials showed an improvement with TMS, every one of them. So it is pretty clear now that in fact, TMS will improve function after a stroke. The ideal time to give it appears to be early, but it can be given late as well, because there are some studies that show that you can still get effect even years after the stroke. Which networks should be targeted? Well, that's what we don't know, because our neurological psychiatric colleagues have not had maps previously to target specific networks. They've simply targeted networks that they think should affect the function. We've been using QuickTone Bold in a very as a beta test site, the first iteration of the product, and have been incredibly pleased with targeted TMS as opposed to non-targeted TMS. The results seem to be a whole lot better. In fact, with depression, 90% of patients appear to be improving as opposed to 40% when given non-targeted. Here's a stroke patient, 71 years old, previous stroke, so in other words, chronic, 4 years ago. There's a pre and post TMS white matter fibers, and you can see these bundles have increased. You can even see the parcellations have increased, and in keeping with that significant improvement, she also gets functional improvement. These were her scores before treatment, and the scores after treatment showed significant improvement in all modalities. This is a patient with multiple sclerosis. He's actually a friend of mine who's got end-stage MS. He is at the stage where the best neurologists in the world have said to him, go home and die, you haven't got longer to live. In fact, the most senior neurologist in Australia said that he's the worst case he's ever seen. The only function he's got is a weak voice. He can speak in a whisper like that. And he's got a little bit of function in his index finger, and that's about it. With that index finger, he really depends on that index finger working well because he works his smartphone, but really that's all he can do. Move his finger and speak. So this is him before TMS, and we've asked him to drop that ball into the jar. He's finding it hard to lift his arm up. He's got a little bit of flexion of his elbow there, but he doesn't even have extension of his fingers. He can't release his grip on that ball. You can see it's incredibly weak. Function is incredibly limited. Okay, we give him TMS. Now TMS is given in 15-minute time slots, and the literature supports good physiotherapy in the half hour after the TMS. So each TMS session takes about 45 minutes. We give them 5 sessions a day for 5 days, and this is him after only 1 day of TMS. So 5 treatments of TMS, and this is the improvement you get in this patient with end-stage MS. So that's in a patient who's recalcitrant to all other treatment with significant functional gain with 1 day of TMS. His lower motor function also, this is him pre-TMS. We've asked him to stand up. Of course he can't. So his helper is going to help him stand up. And basically his helper has to pull him up and then support him. Not bad actually, but certainly he couldn't be left alone. He's wanting to sit down, and after, I forget what it was now, after a minute, he basically has to sit down. He can't stand up any longer. This is after 4 days of TMS. His helper still has to help him up, but nevertheless, he's putting much more weight on his own legs. I don't know what happened to the volume. It's weird, it was working. The reason I wanted to hear that is because he's such, his spirits and his mental and emotional well-being has improved so much. He's actually trying to dance to the music, and he's even miming the words to the music. So I got a letter from his daughter saying that I've got my dad back. He's got a newfound attitude. We've improved his whole mentation and his whole attitude. And I won't take you through it, but he stands for 3 minutes, basically by himself. His helper doesn't have to hold him at all, and he's even sort of trying to dance a little bit while he's standing. So that's 2 minutes and 2.5 minutes. And that improvement has continued. Again, I got a letter from a friend of his that says he's a new person. It's the same old wall back again. Here's a patient who had an immediate stroke after my surgery. So you can see this is the GBM of the thalamus, a very good resection, but unfortunately he's paralyzed in his upper limb. So complete paralysis of the right upper limb, partial paralysis of the leg, and that's a paralysis that unfortunately is probably going to be permanent because even at a week he had made no recovery. We mapped him, we looked at his networks, we did that matrix on him, we tried to find a network that we could stimulate or inhibit to try and normalize his brain. And this is him 1 day TMS. No, it's okay. So this is after 1 day of TMS and he's no better. This is 2 days of TMS or 1.5 days of TMS, and he's already starting to get some function back in his hand. He's got a little bit of flexion, extension, some spreading of his fingers. He's very, this is tears of joy. He's even got a bit of elbow flexion. He's very, very happy. That's him lifting his own elbow, so a bit of elbow flexion. And this is only after a few days of TMS. After 7 days of TMS, he basically has a miraculous improvement in his upper limb, the sort of improvement that you would never see normally in someone after surgery who's completely plegic for a week. This is only after a week of TMS, and watch, he's even got grip and release of his hand. His lower limb improved the same. This is in day 1, no TMS, no anti-gravity. He's just sliding that along the floor, can't lift it. We give him 1 treatment of TMS, just 1 treatment, and he's got anti-gravity. And then after a week, walking with assistance. He's a patient who's a hippie, so he didn't want chemotherapy or radiotherapy. I had taken out his tumour a year before. Then he got a recurrence. It's a malignant tumour. He wanted me to take it out. I said I wouldn't because it would make him completely paralysed in his leg. He said, I don't want chemotherapy, I don't want radiotherapy, I will only accept surgery, so please do it. And I thought, well, if I'm going to do it, I'll really paralyse him. And I did a supramarginal resection and completely paralysed his leg. So no movement in his leg. This physiotherapist is pushing his leg along. And no expected recovery. We start TMS on him early because he's so young. Day 3, we give him 1 session. Day 4, he's got a little bit of adduction of his thigh. Day 2, he's walking with assistance. Day 3, he's walking without assistance with a cane. Day 4, he's even got foot flexion. And day 5 after TMS, he rides a surfboard and he wants to know if he can ride a surfboard. And he's even got balance and fine proprioceptive response after 5 days of TMS in someone in whom I've resected his entire motor strip. Here's another patient. This is not from my clinic. We have a similar clinic in South Africa with one of my previous fellows. Good resection of the tumour, a big resection. After surgery, the patient couldn't work the pedal on the car. So now the patient's instructed to please put your foot on the clutch. You can barely find the clutch, barely push it down. Do it again, please. Finds it hard to coordinate it. Eventually hits the clutch after a few attempts, pushes it down. This is after 1 day of TMS, apparently. That's 1 day of TMS. Here's another patient. I'm not quite sure the story here, but nevertheless, this is the function before TMS. This is the leg function before TMS. And this is the hand function after TMS. He's even got fine motor movement, and this is his running. This is more than after TMS. Apparently, this was about a month after the end of TMS. Oh my God, how do you? That was immediately after TMS, and this was a little bit.
Seine fingers, open his fist, yeah.
You don't have to take my word for it. There's now evidence in the literature. This is class 1 evidence, in other words, double-blinded, placebo-controlled study. So it was blinded, it was randomized, the placebo control was sham TMS, and it shows that non-targeted, so navigated just means they used a navigation to hit the motor area, but it wasn't targeted with a map. So non-targeted TMS improves the outcome of post-surgical patients after surgery. This is a couple of patients with depression, 40-year-old executive, had multiple treatments of CBT and medications. Non-targeted TMS didn't do any good at all. Again, it's like turning the lights out and trying to shoot the target with a shotgun. He then became suicidal, was unable to work, he had crippling anxiety, he would break down to tears at the drop of a hat. So we gave him targeted TMS, which is like turning the lights on, hit the target, and here's the targets. This is right T1M, which is very typically affected in depression. This is 8AV, typically affected in anxiety. We give him TMS, he comes back and says, you've got rid of my depression, but I'm still anxious. He's still got some overactivity of his 8AV, but his depression network is completely back to normal. So again, a good validation of the software and a great result in terms of depression. This is the wife of a doctor. She doesn't want to take medications. She's very, very depressed. And again, you can see all the terrible red areas pre-TMS and a significant reduction in the red areas after TMS and a significant improvement. There is clear improvement. Anyway, what does it say? I am pleased to report that there's been considerable improvement in the mental state, both objectively and subjectively. So the bottom line is that you can turn the lights on. So the bottom line is that this is now an absolute game changer. It has revolutionized our understanding of the human brain. Companies like Omniscient has brought that revolution to our fingertips so that even people like me who aren't that knowledgeable about connectomics can use that information because the software allows us to sort of apply it to our patients on a daily basis. It's not only going to be applicable to neurologists and neurosurgeons, but I think it's going to be applicable to anyone who's dealing with any sort of brain illness, especially our psychiatry colleagues. So thank you very much for your attention, and if there's any questions, I'd be very happy to answer. Thank you.
Thank you, Dr. Theo. That was really an eye-opening talk for all of us, and I'm sure that henceforth the way we gauge our surgical and surgical outcomes in patients would really change, and this is something that we have to incorporate into our daily practice. We'll take some questions first.
Good evening, sir. I'm Dr. Priyank. I'm final year resident in neurosurgery. I have a question regarding TMS. So, sir, like regarding the surgery which you explained on a healthy, saying that after removing of the motor strip, he regained his function. So, how do we explain that, sir? Like having the damaged area is a different thing, but completely removal of a strip and again regaining the function.
So remember, it's all about plasticity. We know people have a stroke where they take out their entire MCA territory, can still improve with the passage of time and physiotherapy. So there are alternative pathways that you can use to compensate for the broken pathways. We know, for example, that the parameter tract has 15% of their fibers that don't cross. So these are potential pathways or highways that you can encourage with TMS. And that's how we believe TMS works. We believe it works by accelerating plasticity. It doesn't destroy anything, it doesn't create anything, it basically encourages and accelerates plasticity.
So one more question, sir. So how long we need to give TMS? You said 5 days for a patient.
Yeah, the literature is pretty clear. In the olden days, they'd give 2 or 3 TMS sessions per week for 6 weeks. And the first iteration of TMS used alpha wave therapy. Now it's theta burst therapy, and it's, the studies in the psychiatry literature show that you can give TMS more concerted. In other words, concentrated over a week. So we give 5 treatments a day for 5 days, 25 treatments all up. Your next question is probably going to be, well, you know, if 25 treatments helps, why not 50 treatments? And we're currently conducting trials where we give them more or less TMS to see if we can make the improvement even better still.
Sorry, one last question, sir. Is that does this have a role in a patient who has a stroke for like a long time? Like patient has been paralyzed for a long time.
It's mostly beneficial when you give it early, but there are some studies, and we showed that few patients where we can improve the stroke even if you give it late. I mean, years late. The one study that looked at chronic stroke patients looked at patients who had had a fixed deficit for 1.5 years. But that lady had a fixed deficit for 4 years, and she's doing it.
Thank you.
Dr. Theo, in the morning you mentioned that it's also being used for pain management.
Yes.
So can you give us some examples of that?
Yeah, so we've got a group of patients now that we've been treating for chronic pain syndrome. So those students who don't know what the chronic pain syndrome is, it has baffled doctors since the beginning of time. These patients aren't necessarily crazy. They don't necessarily have secondary gain. They don't like their pain just as much as anyone would like pain. But somehow they have a very low threshold to pain. And so much so that it incapacitates them, and they often search for answers to try and fix their pain. Operations on their back, narcotics, pharmacology, acupuncture, you name it. They'll try anything to get rid of their pain. It turns out that the perception of pain has a lot to do with the functioning of the salience network. And so when salience is dysfunctional, you can get pain syndromes. Chronic fatigue syndrome, repetitive strain injury, chronic pain syndrome, chronic fatigue syndrome. They're all reflections of a dysfunctional salience network. So what we've done is we've scanned with QuickTone Bold. We've scanned these patients and found, in fact, that they do have an abnormal salience network, and we're modifying their network with TMS with excellent results. I'm talking making patients who have been in pain for years and years and years pain-free. We're doing the same with tinnitus. No one understands why people get tinnitus. There are otological causes of tinnitus, and there are central nervous system causes of tinnitus. We don't know what causes it, but we are now showing that tinnitus, and we just written our first paper, is probably on the same spectrum as anxiety and depression. It's all on the same spectrum. 8AV, right S6 to 8, right T1M, left T1M. And so we've been treating patients with tinnitus by treating those targets, those anxiety targets, again with great results. If we don't get rid of the tinnitus, we've had a few patients say, look, I've still got a bit of hip ringing in my ears, but it doesn't bother me anymore. So, another great application for TMS.
And Dr. Theo, one last thing. So even in patients with movement disorders, Parkinsonism, or if you have patients with dementia, you use the same kind. How does it compare with, say, deep brain stimulation in these cases, so TMS versus that? And whenever you do use TMS, are the effects of it prolonged, or do you have to give it again, repeat the stimulation? Like we have continuous stimulation in the deep brain stimulation implant.
Yeah.
So TMS has
So an answer
how
to
often
your
does
first
it have to
question
be?
is that the more scans we do, the more accurate machine learning will become, the more accurate those algorithms will become. Omniscient is currently working with psychiatrists in China, in Shenzhen, where they have the largest psychiatric hospital in the world, 2,000 inpatient beds, 1 million outpatient psychiatry patients every year. And if we want to develop algorithms or templates for schizophrenia, for example, they can give us like 200 schizophrenia scans in one hit, just like that. So things like Alzheimer's and Parkinson's, yes, we're not at the stage where we can say, look, this is a typical appearance of someone with Alzheimer's, but we're getting close to it. So we've treated several patients with Alzheimer's in our clinic, and I must say the results are initially fantastic, but it wears off pretty quickly. So that brings us up to your second question. Your second question is, how long-term is the treatment? Is it curative or is it a treatment? And I'm sorry to say that our psychiatrist colleagues have shown us pretty nicely that most patients need top-ups of TMS and needs further treatments, and we're finding the same thing. That after 6 to 12 months, sort of the effect starts wearing off, and then we give them a top-up.
Even in the tumor resection, post tumor resection.
Even those patients, yeah.
Do we have any more?
Good afternoon. I'm Dr. Vinay Prabhu from the Department of Radiology. Since these neuronal networks are still developing in children, is there any scope for identifying reasons for behavioral disorders in children and using TMS or any other method to address it, but brain mapping to actually follow them up and see how they are able to change over a period of time as they grow?
Yeah. Look, it's a great question. I'm not an expert on it. If Mike Shagru was here, he'd be able to give you like an hour-long response. I've asked him the same thing, and it goes something like this. The networks in children are absolutely different to the networks in adults. We know that central executive network, for example, doesn't start formulating, doesn't start building until about 13 years of age, and then is completed around 30 years of age. So yes, it is a dynamic phenomenon, these development of networks, as you become more mature and as your brain matures. That's the first thing. So kids are different to adults. The second thing is that at the moment we are getting our functional information from resting state MRI. Now I don't know if you know much about it, of course you're a radiologist, sorry, but resting state MRI scan is typically inaccurate because the ratio between oxygenated and deoxygenated blood is very, very slight, so it's subject to a lot of noise, movement, for example, the movement of your heartbeat. All those things affect the quality of a resting state MRI scan. These guys are omniscient. They're absolute geniuses, and I don't know how they've done it, but they have developed a software program that can now take away a lot of that noise. They can eliminate the heartbeat, for example, and make resting state MRI scan even more accurate. But here's the trouble. If you want to do a resting state MRI scan on a kid, you can't anesthetize them. And you can't sedate them because that will affect the activity of the networks. So you are dependent on a cooperative child. Now, a lot of these children who I believe we can help with autism, for example, they won't lie still. So you've got to anesthetize them, or that unfortunately then ruins the true interpretation of the networks. But we know that autism is part of DMN. If you damage DMN, you get autism. So it'd be great if we could somehow get around that situation. Clever people like yourself and these guys, they need to work on it so that we can scan and get good information on children. Because I truly believe TMS and modifying networks will help those people with autism and schizophrenia.
Thank you.
Thanks, those were some great insights. Do we have any last questions? No? All right. Thank you, Dr. Teo.
Pleasure, thank you.
Please remain on guys. I'd like to invite our Dean, Dr. Mehta, to felicitate you with a little memento of our gratitude.
I hope it's food. I just love Indian food, except the sweets are very, very sweet. And you can see why obesity is increasing because the food is just so sweet and so nice. It is a worthy world. Can you take your photo?
Thank you, Dr. Teo. Madam, if you would just like to say a few words for Dr. Sunil concludes.
It's a rather difficult task for me to even make a few remarks because the first thought that comes to my mind is, am I somebody who is odd one in this learned crowd of surgeons. I'm almost going to say super surgeons because you're dealing with the brain. And but I realized in the morning, and I went through a little bit of more of his personality, that he's also a great supporter of girls' rights. Am I right? I heard that. And I thought in that context, I may not be the odd one in thanking him for everything and thanking him absolutely for the great enlightening talk which you gave just now. It's really opened a very broad outlook for all of us because as a physician, what I understood about the brain mapping and its various aspects and the close connection of psychiatry and neuropsychiatry. I was just setting to think whether since today is an era of personalized medicine, customized care plans, but how possible it's going to be across the framework of all disease and across population is your guess is as good as my guess. But I was looking at certain conditions where this would probably be useful to customize, especially when we look at neuropsychiatric side effects of certain medications. That's where probably brain mapping and then taking precautionary measures is going to be useful. Because I have encountered a few neuropsychiatric side effects using the anti-epileptic medication levetiracetam, and it took us quite a while to decide that it was the side effect of the drug. So, and these drugs are going to be there administered for the patient on a long-term basis. So this is where I feel personalized medicine and not the genetic part of it, I'm looking at the brain mapping with your softwares. If that's going to give us a clue to this, then probably we can save the patient a lot of misery. So another area where this could, we have encountered a large, good percentage of post-COVID long-lasting fatigue syndromes. And we've worked them up for other causes of fatigue. And probably we were clueless as to why this. We were groping in the dark, yes. Especially these chronic symptoms post-COVID, which have lasted longer than 6 months. So now what I'm aware of is neurobiological studies which are going to come up to look at what's happened. There's probably another area where this mapping would help. And as you already said, the chronic pain syndromes, where you have worked up for almost all the possible etiologies. And the pain is disabling. As you rightly mentioned, the emotional component and the pain perception in a given individual, which complicates the whole issue. But yet, to make them pain free is people will be really blessed for that. I don't know whether it also applies to the pains, the severe pains of oncology related. I mean, the other cancers of or solid tumors, where it's going to be a kind of palliative and terminal care. So this is absolutely amazing, and I really wish all the young, new next generation surgeons we have in the institute will follow suit, keep in touch with Sir, and get yourselves more and more updated and bring it on and translate it to these countries. And something else which we really need to applaud about Dr. Charlie is his interest in extending his or skill and knowledge transfer to the young doctors across countries and his interest in developing countries. So we are very grateful to you on behalf of everybody for having spent your valuable time sharing so much knowledge. And I'm sure you have kindled a lot of interest in young brains. And please give us the liberty to trouble you in future so that you visit us again to enlighten a lot more people. Thank you so much. Thank you, sir, for being here once.
Thank you so much, Medha ma'am. Those were some very kind words. I would like to invite Dr. Sunil Furtado now to give us the vote of thanks and end the proceedings.
A very good afternoon to all. On behalf of the Department of Neurosurgery, I'm glad to be standing here before you to express my vote of thanks. A special thanks to our Chief Speaker, Professor Charlie Teo, for coming to our institute here at Ramaya Medical College and Hospital at short notice and sharing your thoughts and research and the utility of connectomics and brain mapping. I'm sure we've learned a lot by your lectures. A special thanks to our in-house speakers led by Dr. Shabri Girishan and Dr. Rakshit Srinivasa and my colleagues for speaking about the brain mapping and its application in networking in neurosciences. We had a great operative demonstration this morning, and for this I'd like to thank Professor Charlie Teo for helping us out in the OT. I'm sure the next time you're here we would have the bipolar as per your specifications. And a special thanks to the neuroanesthesia team, my team of residents, the OT staff and OT assistants, our department admin assistant, Mrs. Hema Ramesh, for the outstanding work that they have put in over the past few days and especially today. Also thanks to my neurology colleagues led by Professor P.T. Acharya for the help extended to us. I would also like to thank Dr. Medha Rao Madam, Principal and Dean, Ramaya Medical College, and for being here today. She spent almost entire day with us. Dr. Shalini Nui Madam, Vice Principal, for being with us. I would also like to thank the President of Ramaya Memorial Hospital, Dr. Gurudev. He's not with us, he's on leave today, but he has provided us with the infrastructure for the program. We would like to thank him too. For the Omniscient company who made this program possible, special thanks to Mr. Rajesh, Matthew Thompson, Ajay, Mel, and the entire team who networked with us from Sydney. Thank you. If they're listening to us on the webcast, a special thanks to them too. Thanks for the support to the pharma companies led by Sun Pharma and Icon Pharma for the hospitality and the audiovisual arrangements for the program. A special mention to Mr. Manish Gaud from the marketing department and Mr. Ravi from the Ramaya Medical College Hospital who made the online webcast possible. And finally, a big thank you to all the participants for your active participation and the constructive discussion that we've had today. And I'm sure that you'll join us for more programs ahead. Thank you one and all. Have a good evening.
Thank you all once again. There is some high tea served outside the auditorium. Please refresh yourselves. Thank you so much for coming.
ವರ್ಕ್ ಮಾಡಿ ಅಲ್ವಾ